Good afternoon, everyone. Welcome to the third meeting of the COVID-19 Health Equity Task Force. I am Minh Nguyen, and I am the designated federal officer for the task force. As a reminder, this meeting is being live streamed and recorded and will be available for viewing at a later time. All materials presented in this meeting will be available at minorityhealth.hhs.gov/HETF, which stands for Health Equity Task Force. We are providing American Sign Language interpretation for these with hearing impairment. Closed captioning for this event will be available both from hhs.gov/live and the Office of Minority Health YouTube channel. Members for the public are invited to provide comments during future meetings. Please let us know in advance via email at COVID-19HETF@hhs.gov. Special assistance or other reasonable accommodations might be arranged if requested at least 10 business days prior to the meeting. Written comments will be accepted up to 7 days after the meeting. Please send comments to COVID-19HETF@hhs.gov. With that, I will turn it over to Dr. Marcella Nunez-Smith, Chair of the Task Force. Madam Chair.
Thank you so much, Dr. Nguyen, and good day, everyone. Welcome to the third meeting of the Federal COVID-19 Health Equity Task Force. Up top, I want to recognize Assistant Secretary Levine, who's also ex officio member. Thank you so much for joining us today to provide updates from HHS. We'll hear about that shortly. Thank you so much to the agency for support of the task force and this work. Also today, a very special welcome to our new federal ex officio members, all of them officially onboarded now. We'll hear from them as well shortly. So the objective of today's meeting is to discuss interim task force recommendations on advancing behavioral health equity. And turning to this priority now reflects the reality that COVID-19 inequities experienced by minoritized and marginalized communities also manifest in suffering from grief, stress, and economic worry, and are superimposed on inequities in access to timely diagnosis and guideline-appropriate treatments that predated the pandemic. So this is an issue that touches virtually every community, countless families. We know that stigma remains a challenge, and especially in the context of substance use disorder, the racialized legacy of drug policy in our country must be acknowledged. And brings us to today, where the reality is that behavioral wellness is still elusive for far too many. Specific groups have been uniquely affected across the lifespan. Our children, youth, our older adults are grappling with social isolation, with loneliness, in addition to the gendered reality of essential workers, with women and women of color overrepresented in fields often on the front line, from domestic workers to teachers to healthcare workers. And an estimated 2 million women have exited the workforce because of caregiving demands, fueling economic stressors for many. Yet connecting with behavioral health care has been made all the more challenging for many this past year. Difficulty finding available providers, available services, sometimes lacking the smartphone or broadband needed to connect with telehealth care or other digital tools. Limited opportunities for culturally, linguistically responsive care, and not having adequate insurance coverage to assuage concerns about cost. So we will tackle this today. Just a reminder to everybody for our global charge. As a task force, we are charged with providing specific recommendations to the president through the coordinator of the COVID-19 response and counselor to the president to mitigate the health and social inequities made all the more evident by the pandemic, and that are driving unequal burden of disease risk, suffering, and all the sequelae in minoritized, marginalized, and medically underserved communities. It is imperative we recognize and that we name the historical as well as the contemporary underpinnings of these structural realities. So as we hold our work together as a collective on the task force, we are mindful that we're taking a very broad lens. We're centering equity across the most affected groups: people with disability, people with justice involvement, our older adults, our rural neighbors, mixed status families, queer and gender diverse people, people of color, indigenous, native people, those on the margins of the economy, and others. I want to say a word about data, because on the data front, we will continue to call it as part of our charge for the complete disaggregated and intersectional data that are necessary for a data-driven response and also a data-driven recovery. And in addressing how we collect, protect, and use data, we are committed to continuously engaging with those who have been made invisible and otherwise harmed by data. And we will always elevate the positive assets, the wisdom that is too often ignored or undervalued in the hardest hit communities as we generate recommendations and guidance, as well as the imperative to be in partnership with community and organizations who are trusted and that elevate the leadership of those with the necessary lived experience and expertise. So again, the focus of today's meeting is behavioral health. We will deliberate interim recommendations that may be modified ahead of the final report. We have an ambitious agenda to cover today. So in the first part of the meeting, we will hear from our invited guest. They will provide some additional framing for our work for today's conversation, as well as for moving forward. And I also want to thank the many subject matter experts who met with task force subcommittees these past weeks and months. This month specific to behavioral health and mental health, and last month specific to equitable vaccine access and vaccine confidence. Just a reminder, the work of the task force is organized across 4 subcommittees. You'll hear from each today: communications and collaborations, data analytics and research, healthcare access and quality, and structural drivers and xenophobia. Each of the 4 task force subcommittees will share their recommendations interim for group consideration and deliberation ahead of public comment. We will then discuss further as needed ahead of task force voting. I want to say a special thank you, of course, to the federal staff team, as well as to all of the task force members. Your work has been tireless. It's a quick sprint that got us here today. Grateful for it. So on this, the last day of National Minority Health Month, and as we ready for Asian American, Native Hawaiian, and Pacific Islander Heritage Month in May, we must remember that equity takes intention and never happens by default. So I remain very grateful to be in this work with all of you. And now back to you, Dr. Went, for our member roll call.
Thank you. Thank you. So now I'll conduct a member roll call. This is for the meeting record. When I call your name, you may respond with present. Ms. Mayra Alvarez.
Present.
Dr. Sarah Bleich.
Present.
Dr. Jessica Kardashian.
Present.
Ms. Angela Hanks. I'll come back. Dr. James Hildred.
Present.
Mr. Andrew Emperado.
Present.
Mr. Victor Joseph.
Present.
Dr. Chanae Khaldun.
Present.
Dr. Rachel Levine.
Present.
Dr. Octavio Martinez.
Present.
Mr. Eric Nguyen. I'll come back. Dr. Marcella Nunez-Smith.
Present.
Dr. Tim Putnam.
Present.
Mr. Vincent Torenzo.
Present.
Ms. Mary Turner.
Present.
Dr. Homer Venters.
Present.
Mr. Bobby Watts.
Present.
Miss Hae-Young Yoon.
Present.
Mr. Eric Nguyen. Miss Angela Hanks. We might experience some technical difficulty. We'll come back for the record. Thank you. Now I turn to Madam Chair. You have a quorum for the meeting.
Thank you so much, Dr. Went. All right, it's my pleasure to again welcome our 17th Assistant Secretary for Health for the U.S. Department of Health and Human Services, Dr. Rachel Levine. Thank you so much for bringing updates from HHS to us. The floor is yours.
Well, good afternoon. Thank you so much, Madam Chair, for that very kind introduction. It is a pleasure to join you again for the third COVID-19 Health Equity Task Force meeting. I am so excited to be here for this important discussion on COVID-19 related mental health and behavioral health inequities. Across America, we are seeing a significant rise in mental health and substance use disorders due to COVID-19, including the physical health implications of the virus, deaths of loved ones, prolonged isolation, the duration of the COVID-19 pandemic, and of course, the challenges to our economy and so much more. Recently, the Centers for Disease Control and Prevention released data confirming a rise in fatal overdoses during the pandemic. And this year's increase in calls to helplines across the country are indicative of the growing anxiety, depression, and trauma that Americans are experiencing. We know that multiple stressors during the pandemic, isolation, illness, grief, job loss, food instability, loss of routines, to name a few, have been so significant to many Americans and presented unprecedented behavioral health challenges across the nation. Now, it is a fact that this pandemic has impacted some specific communities more than others. And this underscores the profound disparities in healthcare that have long plagued our nation for far too long. The health of racial and ethnic minority groups and economically disadvantaged persons has been disproportionately impacted by this pandemic. Individuals in these communities do remain at higher risk for COVID-19 infection, for death, and increased psychological distress. Addressing the COVID-19 mental and behavioral health impacts on vulnerable and disenfranchised populations is really among one of the top priorities of the Biden-Harris administration. And as your Assistant Secretary for Health, I am committed to giving every tool at my disposal, building off of the methods that I use at the state level, including partnership building and beyond. Our frontline healthcare workers and first responders have also been exposed to numerous stressors: exhaustion, patient illness and death, risk of infection, separation from loved ones. They are all contributing factors to the psychological distresses and behavioral health issues, which include mental health and substance abuse. One of our goals at HHS is to ensure and maintain the behavioral health of healthcare workers as a critical factor in combating COVID-19, as well as enhancing our preparedness and response and recovery capacity. It is so important that we address the emergent and acute mental and behavioral health needs for all, as well as take the preventative actions to avert future human suffering due to mental health disorders and addictions stemming from the impacts of the pandemic. At HHS, we have taken several critical steps to expand access to necessary mental health and substance use disorder services as the government works and the administration work to reopen the economy. Recently, the Centers for Medicare and Medicaid Services issued temporary measures to make it easier for people enrolled in Medicare, Medicaid, and CHIP to receive medical care through telehealth services, including mental health counseling. These changes have allowed providers to meet patients and conduct telehealth services when the patients are in their homes. In addition, nearly 15 million Americans who currently lack health insurance and many current enrollees may be eligible to receive additional financial support in obtaining coverage through the CMS Marketplace as part of the American Rescue Plan. Eligible consumers can apply through healthcare.gov through August 15th, 2021 to gain access to the special enrollment period to change or update their plan choices. Last month, the Biden-Harris administration announced $2.5 billion in block grant funding to SAMHSA for states and territories to address the nation's mental health and addiction crisis, which has worsened during the COVID-19 pandemic. This SAMHSA funding will direct $1.65 billion for substance abuse prevention and treatment, and $825 million for comprehensive community mental health services. And just this week, Health and Human Services issued new practice guidelines for the administration of buprenorphine for treating opioid use disorder. This exempts eligible practitioners from the federal certification requirements that are related to training, counseling, and other ancillary services that are needed to obtain a waiver, authorizing the dispensing or prescription of buprenorphine. These practice guidelines are intended to help expand access to treatment and reduce stigma through integrating opioid use disorder treatment and care with primary care services. During this time of increased urgency, HHS is continuing to assure that the right funding and guidelines are in place to provide pathways to prevention, intervention, treatment, and recovery services, especially for underserved populations. In conclusion, it is important that we continue to move quickly to provide the necessary funding, to expand infrastructure in place and support all levels of government and other public-private partnerships to build back better the mental and behavioral health systems of care. I'm a positive and optimistic person, and I am confident that the work and recommendations from this task force will help us to mitigate and prevent the mental and behavioral health inequities caused or exacerbated by the COVID-19 pandemic. I look forward to the presentations and recommendations from today's meeting. Thank you, Madam Chair.
Thank you so much, Dr. Levine. Very grateful for those updates from HHS and for your service as an ex officio member of this task force. I will just pick up where you left off. We are now ready for our presentations from our guests who are with us today. We're very grateful. What I will do is I will introduce each of our three speakers. Right now, they'll speak in succession. I ask the task force members, please note your questions. We will ask them the questions at the end of all three presentations. First, we will hear from Drs. Evans and Akbar, who are here from the American Psychological Association. So Dr. Arthur Evans, Jr. Is CEO of the American Psychological Association. This is the leading scientific and professional organization representing psychology in the United States. Dr. Evans holds a doctorate in clinical community psychology from the University of Maryland and a master's degree in experimental psychology from Florida Atlantic University, where he was inducted into the university's Alumni Hall of Fame. Before joining APA in March of 2017, Dr. Evans spent 12 years as commissioner of Philadelphia's $1.5 billion Department of Behavioral Health and Intellectual Disability Services. Prior to Philadelphia, Dr. Evans was Deputy Commissioner for the Connecticut Department of Mental Health and Addiction Services. Dr. Evans has held faculty appointments at the Yale University School of Medicine, University of Pennsylvania's Perelman School of Medicine, Philadelphia College of Osteopathic Medicine, and the Drexel School of Public Health. Dr. Maisa Akbar is Chief Diversity Officer of the American Psychological Association. And before assuming this post, she was the founder and Chief Executive Officer of a clinical practice based in New Haven, Connecticut that specialized in race-based trauma. Dr. Akbar held a faculty appointment at the Yale School of Medicine Child Study Center for almost 2 decades, advancing multicultural clinical practice and cultural responsiveness and psychological training. And Dr. Akbar holds a PhD in clinical psychology from St. Louis University, an MS in community psychology from Florida Agricultural and Mechanical University in Tallahassee, and a BA in psychology from the State University of New York at Albany. Drs. Evans and Akbar will be co-presenting. And then we will hear from Dr. Niranjan Karnik, MD, PhD, who is the Cynthia Wiegans Harris MD Professor of Psychiatry and Behavioral Sciences and Associate Dean for Community Behavioral Health at Rush Medical College, with conjoint faculty appointments in the Graduate College and the Department of Community Systems and Mental Health Nursing at the Rush College of Nursing. He also serves as director of the Great Lakes node of the National Drug Abuse Treatment Clinical Trials Network. He's the co-director of the Rush University of Chicago Institute for Translational Medicine KL2 Career Development Award Program. And in the past, he has worked with refugee children on the Pakistan-Afghan border, street children in India, foster youth in Central Illinois, and incarcerated youth in California. He worked at a youth homeless shelter in San Francisco and is continuing this work with homeless youth in Chicago. Dr. Karnik's MD, PhD, and an AM in sociology from the University of Illinois. So thank you all so much in advance for providing additional context for our discussion today. Without further ado, I will turn it over to Doctors Evan and Akbar. Thank you.
Okay, I'm sharing my screen. Can everyone see my screen? Okay.
Yes, we can.
Okay, and so first we have no financial disclosures to disclose. And we want to thank you for this opportunity. We're actually quite honored to be asked to come and share with you today, and hope that this helped you in your deliberations. There are 5 points that we want to make today. The first is that COVID has had an enormous impact, as you heard from Dr. Levine, on the nation's mental health, and that the pandemic our recovery from the pandemic must include and be inclusive of thinking about and addressing the nation's psychological well-being. The second point is this, that the pre-existing issues around systemic racism have complicated and exacerbated the impact of COVID on communities of color mental health. The third point is that the paradigm that we have today is inadequate for addressing the level of complexity and magnitude of the problem. And we're going to share some data that illustrate that. Then we're going to present to you a framework, an alternative framework, and then some recommendations. So to put all of this into context, we are experiencing, and as a nation have gone through, a very significant pandemic that has had a significant impact on our mental health. But after the pandemic started, we started to understand that we had these very significant disparities, particularly for communities of color, which added to the psychological distress that we were all experiencing as a result of the pandemic. And then on top of that, we had the economic stressors and the economic impact, which we know also contributes to our mental health and our mental well-being, which communities of color have been disproportionately impacted by. On top of that, we, during the summer, have experienced all of those events where issues around racial justice were brought to bear, and again, contributing to the levels of stress, and then a very tumultuous political environment. So when we look at all of those events, it starts to show up in the data. We do a survey each year to look at the nation's stress levels, and immediately after the pandemic started, we saw a rise in the stress levels in the nation. First time we had seen that in over a decade. And those stress levels have remained pretty high throughout the pandemic. We know that 80% of Americans are saying that the pandemic has been a significant source of stress. But we're also seeing it in terms of how the pandemic is playing out on our physical and mental health in other ways. 6 in 10 people are reporting undesired weight change, either gaining weight or losing weight, with the average weight gain being about 29 pounds. We're seeing that people are having sleep disturbances. 2/3 of Americans, people are drinking more to cope with the stress related to the pandemic. We're seeing increased symptomatology, more people reporting symptoms related to anxiety and depression. And in fact, the rates are about 3 to 4 times what they were before the pandemic. We're seeing increased overdoses and increased partner violence. And for communities of color, communities of color have been disproportionately impacted. And what Dr. Akbar is going to talk about is really the confluence of the pandemic along with longstanding racial inequities and how that's playing out on our mental health. Dr. Akbar?
Thank you, Dr. Evans, for setting the stage for this conversation, and in particular to take a look at what we mean when we're talking about the impact of discrimination and trauma on communities of color. Next slide, please. I want us to make sure that we all have a common understanding and definition for the way that we think about a phenomenon such as like racial trauma. Racial trauma is the cumulative effects of racism on an individual's mental and physical health. It has been linked with feelings of anxiety, depression, and suicide, as well as other physical conditions such as high blood pressure and obesity. Racial trauma has been in existence for generations, and it evolves throughout the lifespan. It has continued to be a chronic and pervasive problem in communities of color. Based on a racial trauma approach, the question we should be asking communities of color should change from what's wrong with you to what happened to you. The lens of racial trauma allows us to humanize the experience that people of color are having and to consider an intersectional lens, particularly in the face of COVID. Research has shown us that discrimination is adversely affecting health, like many of you have noted. Little ways in which a person's dignity is chipped away predicts poorer mental health outcomes in a host of physical health problems. In fact, some research suggests that racism itself is a killer. Next slide, please. I want to be able to demonstrate that for the intersectionality of COVID and racial trauma, it is not a one-shot deal. In fact, it's something that we see throughout the lifespan. And when it comes particularly to family and adult health, what we have to keep in mind is that it is not just COVID that communities of color are affected by. It is the compounding challenges that were amplified by COVID that we're contending. So let's just take a few examples. Let's look at the ongoing discrimination in our healthcare system as it exacerbates disparities in maternal health during COVID-19, particularly for Black and Indigenous women. The long-term psychological toll of racism puts Black and American Indian, Native Alaskan women at higher ranges for medical and mental health conditions that threaten not just their lives, but the lives of their infants. Notably, the pregnancy mortality rate for Black women with a completed education is 1.6 times higher than the rate of white women with less than a high school diploma. COVID continues to play a devastating role in families of color, with emerging evidence of increased stress for families struggling to manage their children's remote school activities due to the lack of technology resources, their own workloads, sometimes even job loss, and exposures to stressful events. The second area that I want to cover is thinking about the overrepresentation of people of color as frontline workers in the healthcare field and serving as first line of defense in response to COVID, and how this contributes to unequal rates of COVID infection and death. For instance, we know that there are unique disparities that intersect with race and gender. In 2020, there was a report that women accounted for all the job losses in December of 2020. But when the data was disaggregated, it revealed that specifically Black and Latina women accounted for most of the job loss. And alternatively, white women had job gains. Black and Latina women disproportionately work in some of the hardest hit sectors within the pandemic, many as frontline workers, often in roles that lack paid sick leave and the ability to work from home. The systemic conditions amplified during COVID are an example of how racial and gender disparities, as well as factors associated to social class and other marginalized identities, lead to stress and ultimately racial trauma. We also know from a psychological perspective that COVID has been associated with neurological challenges, as well as a host of psychological adjustments associated to grief, loss, complex trauma, anxiety, and depression, just to name a few. But let's look at it from the perspective of a racial empathy gap that happens when white physicians dismiss the self-reports of Black and Brown patients and distrust the reports of their pain level. A meta-analysis of 20 years of studies across settings found that Black patients were 22% less likely than white patients to receive any pain medication. In fact, 40% of first and second year medical students endorsed the belief that Black people's skin is thicker and have less sensitive nerve endings than white people. Look, racism has fostered and maintained trauma and leads to existing in a state of survival mode due to a host of inequities and limited resources. How will we see the trauma of COVID and racism in the future? We're going to see it in the exacerbation and the likely manifestation of challenges such as increased community violence, domestic violence, suicide, increased substance use, and overdose. A study of suicide patterns done right in Maryland during the COVID pandemic found that completed suicides approximately doubled in residents who identified as Blacks, whereas completed suicides were approximately half for white residents. This is a ripple effect concerning the day-to-day life of families of color. We don't tend to tie trauma to racism enough. However, as psychologist Janet Helms will say, hashtag racial trauma is real. Next slide, please. Now I want to focus our attention on children and adolescents. It's so important to consider them in this conversation as we prepare students to go back into their school buildings, many who have already, and as we need to address the mental health consequences and trauma experiences for the last 15 months as they have battled COVID. The historical and current harms of the medical systems have led to cultural mistrust and contributes to racial trauma and the often belief around vaccine hesitancy, especially for school-age parents. Generations of racism and mistreatment at the hands of medical professionals have left many Black Americans distrustful of the healthcare system and wary of taking the COVID-19 vaccine. In an October 2020 poll, 7 out of 10 Black Americans said they were treated unfairly by the healthcare system, and 55% say that they are completely distrustful. Psychological science provides a lens around behavioral responses to vaccine acceptance. COVID has exacerbated not just the way that kids are showing up, but the behavioral health challenges as it relates to loneliness, social isolation, increased prevalence of divorce, and for children of color, an uptick in racial trauma. The portion of mental health related ER visits or emergency room visits among children has increased 66% between April of 2019 and April of 2020. Nearly 3 in 10 parents report that their children are already experiencing harm to their emotional and mental health because of social distancing and closures. 14% of children are approaching their limits, saying if social isolation continues, their mental health will inevitably suffer. And we already know that there are certain communities, like the Native American communities and children, who have traditionally reported the highest rates of depression than any racial group. And the suicide death rates for those, the highest suicide rates for those ages 15 to 19. COVID has led to long-term impacts in learning loss and in the widened educational gap in students of color, as well as a delay and missed developmental milestones. I'm going to close this conversation by talking about racism and its implications on adverse childhood experiences, or ACE, in which we have historically known to be high in children of color. You combine that now with the exposure to racial trauma, COVID-19, and the racism pandemic, and what you're seeing is that over 10% of Black children ages 0 to 18 have experienced at least one individual or interpersonal act of racism against them. Black children are more likely to have higher ACE scores compared to white children, and Black children are overrepresented among children with 2 or more ACE scores. And what does that really mean? How do we contextualize that data? Well, what that means is that up to 1.9 million cases of heart disease and 21 million cases of depression could have been potentially avoided if we could prevent the number of ACE exposures to children. These long-term problems will not be resolved after herd immunity. For a subset of people of color, there will be long-term psychological responses, and we must begin declaring racism and racial trauma as a public health crisis. A civic education campaign on racism and destigmatizing mental health, followed by increased access to behavioral health and racial trauma treatment, should be the civil right of every person of color. Tackling racial trauma in COVID requires a multi-layer commitment, a paradigm shift, and an innovative approach to mental health equity, which Dr. Evans will cover now.
So thank you, Dr. Akbar. So the way we're going to end our presentation is really offering an alternative framework for thinking about behavioral health. And I want to start with what our current paradigm is. This is a sort of depiction of the population. About 75% of the population at any given time doesn't have a mental health diagnosis. About 25% does. And there are a number of problems with the way we address mental health in this country, but let me point out 2 of them. The first is that the way our system works is that if you're above the line, there are resources. You can have access to mental health resources, and so you have access to those services. If, however, you're below the line, there are no resources. In fact, most mental health systems spend less than 3% of their budget on non-treatment related services, which means we've missed all of the opportunities for prevention and early intervention. And so we have a very reactive system that is extremely detrimental to communities of color because there are already delays in people coming into care. And we've set up a system that actually fosters and promotes that. The second problem is that the way our system assumes that the 75% of people who are below that diagnostic line don't have any clinical needs. Mental health issues really occur on a continuum. And as you could see from the data that I presented earlier, a lot of the population right now is struggling. People are experiencing extreme amounts of stress. People are dealing with a lot of psychological distress because of all the issues that they're dealing with. But we have a healthcare system that basically will ignore them until they reach some magical line of having a diagnosis. And in most systems, it's not just crossing that line, but you almost have to be in crisis. So we want to offer a different way to think about how our system should be set up, and then give you some recommendations around that are consistent with this. The first is if we redivided the population into 3 rough categories: people who have a diagnosis, people who are at risk, greater risk, and you've heard Dr. Akbar talk about the risk factors, the things that put people at greater risk, and then people who are generally healthy and are doing okay. And it's important to remember that even with everything that we're doing, there are lots of people in the population who are doing okay. The point we're making is right now, there are a lot of people who are not. So if this was the way we started to look at our approach, we'd have 3 different strategies. One is to make sure that we have effective and efficient clinical care. Often when people talk about a population health approach, or when people hear that, they believe that that means turning from clinical care to more widespread general public, but it really doesn't mean that. It means that we have to address clinical care, but we also have to think about communities that are at risk and people who are at risk. And there our goal is to mitigate the risk if we can, or intervene early. And then if the last point is that we need to make sure that we are doing things to promote psychological health, something that we don't generally do when it comes to behavioral health. We do that for physical health, eating right, exercise. We know those things are predictive of better physical health outcomes. We actually know a lot about maintaining psychological health, but we don't routinely do that. So the recommendations that we have are in 5 different areas, and because of time, we're going to give you our recommendations in writing. But I want to just high level share with you how we're thinking about this. Number one, it is important to strengthen the current mental health system. The system was not adequately funded prior to the pandemic, and we certainly, given the level of symptomatology and distress that we have in our population, we have to make sure that the current system has that infrastructure. And so we have a whole series of recommendations from telehealth to mental health parity. Secondly, we have to address social determinants of mental health and behavioral health. We know that healthcare only accounts for about 10% of the variance in our health status. 90% of how healthy we are is determined by things outside of healthcare. And if we're going to have an effective strategy around addressing these inequities in behavioral health care, we have to have other parts of government be a part of those strategies. For example, housing is a very strong predictor of how healthy, psychologically healthy people will be. Thirdly, we need to have a data-driven approach. We know that disparities vary from community to community and from geographic area to geographic area. So the only way that you can really address inequities is to make sure that we have the behavioral health surveillance data, but it's also, we need to make sure that we have research in this area. Our Office for Minority Health, for example, needs to have a larger portfolio on behavioral health research. We need to have more prevention and early intervention, not waiting for people to need a diagnosis before we can help them. And what that means is that we have to have flexible funding. SAMHSA needs to have more dollars that allow them to provide flexible funding to single state authorities so that they can design the kind of prevention and early interventions that are needed for communities in their state. And then finally, we need to build community resilience. It is important to understand that every community that we're talking about has strengths, and our approach needs not only to look at how do we address the challenges, but how do we build on the strengths. And so making sure that we have resources for mental health literacy, behavioral activation, doing psychoeducation so that people understand how to access the services that they need would be examples of that. My final point is this, that I really believe, and we believe, that inherent in every community is the wisdom to solve its own problem. These are actually members of the Burmese and Bhutanese communities in Philadelphia, where I worked before I came to APA. When you go to these communities, they understand the issues. They understand the solutions. What we have to do is to provide the resources and the expertise from our field to help create those solutions. And when we do that, we can really address the needs of people in ways that can be quite impactful. So with that, we're going to say thank you again, and we look forward to your questions.
Thank you so much, Drs. Akbar and Evans, but we'll hold our questions until after we hear from Dr. Karnik. Dr. Karnik, please.
Thank you, Dr. Nunez-Smith, Secretary Levine, members of the task force, and colleagues. Thank you for the opportunity to address you today. I plan to focus my comments on interventions, given that Dr. Evans and Dr. Akbar have really outlined the problems so well. I don't think that there's a need for me to reiterate that. And I want to focus these comments on actions that can address inequities related to mental health and substance use in the context of COVID-19. So a couple observations that I will just kind of lay out before you. As you are all aware, COVID-19 exacerbated disparities that were already at play. What we did prior to COVID-19 was already inadequate, and Dr. Evans has just made that point very articulately. We need to really think about bold action with large-scale interventions. This is not a time for us to engage in pilot projects. In fact, We know what works. We have great evidence of interventions that can be used in this moment. And it is my contention that we need to really leapfrog our changes rather than relying on the traditional developmental evolution of care systems. It will take far too long if we do that. And we need to really think about building a new system for the future, and perhaps even giving communities that have been disproportionately impacted the best care and evolving the care beyond what any other healthcare system has seen. So I'll begin by noting over the past several months, I'd say 6-8 months, we have had funding, and I will say that at this point my disclosures are that I have funding from National Institutes of Health, from SAMHSA, as well as through a contract that originates with the state of Illinois that is SAMHSA money in terms of the SOR block grant money. And that constitutes the funding that I have. I have no industry ties or anything of that sort. Under one of those grants, which was through the NIDA Clinical Trials Network, and is referred to as CTN Protocol 111, and this is on the NIDA's website. This actually allowed us to look at COVID-19 data and substance misuse. And what we see in that data won't surprise any of you. There's enormous overrepresentation in this population of Black and Latino people who were hospitalized in Chicago at our hospital for complications related to COVID-19. The pandemic impacted these populations that were already suffering so disproportionately. And one of the things that emerges, I think, out of our visualizing this data, and my colleagues were accurate in terms of outlining the fact that so many structural disparities exist not only in our communities but in our healthcare system as well, and we can see that in the data likewise. But we need community-driven solutions, right? And Dr. Evans just indicated that at the end of his slide. And I want to point your attention to two solutions that I think are worth considering. One is called CETA, or Common Elements Treatment Approach. My colleague, Dr. Laura Murray from Johns Hopkins, has worked on this for several years. She developed CETA as a kind of base intervention in cognitive behavioral therapy that could be done by lay people. And the fact is she's done over half a dozen clinical trials in different contexts around the world with different target populations. And she has successfully shown that you can train lay people to do this intervention with fidelity and effectiveness. So we've been taking this intervention and trying to deploy this pre-COVID-19, but even through the pandemic now, on the west side of Chicago through what we call the West Side Behavioral Health Initiative. And we've been training partner organizations and individuals within those organizations to deploy this treatment. And the idea here is that people are coming in distress. And for this type of first-line intervention, we don't necessarily even need to know whether it's anxiety or depression or substance use. It could be anything that's causing that general distress. And CETA would be an appropriate first-line intervention to try with this individual. And if it works, then the person gets some relief, and the intervention is very basic and modularized and can be done in a short period of time. And if it doesn't work, if the person doesn't respond, then we can refer them into the professional system of care. So we back up our community partners when they do this. We've now also done a limited intervention trial in Effingham County in central Illinois, which is a rural county. And through our program, our Road Home program, we have a former Tillman scholar, psychologist by the name of Blake Schroeder, who's been doing this there. And I got a chance to talk to Blake yesterday, and Blake is having incredible outcomes using this there. So this framework, we believe, could be used across multiple contexts and benefit our healthcare system by creating a workforce of lay people or community health workers, peer recovery specialists, individuals who are grounded in the local context and can be there for their neighbors and friends. In parallel to this, we have been doing another trial of an intervention called FOCUS, which stands for Families Overcoming Under Stress. This was developed out of UCLA for the Department of Defense. FOCUS is used across the entire Special Forces system globally as an intervention to build resilience amongst families that are facing stress. UCLA and our team are taking focus out of the military and defense population of families and trying to deploy it in community context for families across our neighborhoods. And we are seeing similar benefits. These types of approaches, and there are others that have clear evidence behind them, they allow local people to have agency. And they are all able to do a degree of cultural tailoring. And by having local individuals do the deployment, they're able to weave that in the moment that they're doing it. This is a form of what one of my former mentors, Brenda Ehart, called intentional neighboring. It's the idea that your neighbors can be there to help you and to be there in a structured way. And a peer-to-peer or community health worker, peer recovery specialist model could really advance and push these models in ways that are scalable and will have impact. Second, I want to point your attention to what Secretary Levine highlighted, which was telehealth. And telehealth has been something that many of us have been pushing for many years in terms of expansion and hoping and building towards this. And it's somewhat tragic that it took COVID-19 to finally open up the ability to use this set of tools. These changes need to be maintained going forward by legislative action that will allow them to be reimbursable and sustainable over the long term. But they exist in the continuing gap of a digital divide that I think all of you will be aware of. There are people who have access to sufficient bandwidth and sufficient technology to access this, but there are many populations that do not. We are in the process, and our colleagues across the country in terms of research and clinicians are moving evidence-based interventions online. We now have successfully deployed 1-week versions of cognitive processing therapy for the treatment of post-traumatic stress disorder in an online module. One of my trainees is doing a similar parallel intervention with narrative exposure therapy. We are in Chicago, we have teams that are doing medications for opioid use disorder in the field with homeless individuals, and the providers coming in via a smartphone, from a street medicine team. And we're able to initiate treatment with medications in the field because of these changes. These are things that are taking evidence-based interventions and moving them online and virtualizing them. This makes sense. This is how you scale, interventions. This obviates us needing to have patients move and be in clinics and take time out of their work schedules. We can bring the care to them where they are. We need a public-private partnership to bridge that digital divide. Google, Comcast, other large companies, we need their help. They have the means and the technology to build into these communities and facilitate this, whether it is our urban internet deserts or our rural internet gaps. These things can be addressed. And the beauty with both of these ideas is the lay provider level of care combined with the telehealth, right, creates an opportunity to have jobs in these local spaces. What we have found, and what you will see if you look at the evidence around this, is that some of the lay people and community health workers and peer recovery specialists who get engaged in the work that they do through this start to feel like this is incredibly meaningful and impactful, and they want to pursue further training. And they will go into social work, and they'll go into nursing and fields where they can build their skill set. Now, what does that do? When you take this community-driven model of care, right, what it enables you to do then is to have individuals from these communities then pursue good paying healthcare jobs that bring resources back into these communities. So you see that everything starts to align if you look at all of this as a system and think about this in terms of the long term, and it would be transformative in what is there. And the final point is that these interventions feed together into what I think are a data-driven precision medicine approach. We can, at this point, use our electronic and digital tools to do assessments in the field, take the results of these measures and risk stratify people and understand who is appropriate for care in the community and who isn't. Our provider partners who are doing some of these interventions, They shouldn't be taking care of individuals with schizophrenia or severe mental illness. Those are individuals who need specialty care in our clinics. But we can screen for those and determine who is appropriate to care for in the community and who needs to be cared for in a clinic or a medical center. Second, we can do targeted interventions using digital interventions. Now, look, digital treatment is not a panacea. You can't just give a bunch of apps to someone and expect them to, heal themselves. That's not going to happen. The digital health literature is clear that these tools have to be combined with people and with care and with coaching and with counseling. And only when they're woven into this context do they provide care. But we do have the ability to push interventions to people who need it if they are engaged in care. And as Dr. Evans pointed out, we want to have tiered care. And by doing these assessments and doing these assessments continuously and routinely, we can tier the care. And by doing so, we can tailor this to individuals' needs. And that's the moment at which a lot of the cultural aspects of the care that we want to provide can be woven into what we want to do. So I'll conclude with the idea that I think this is the time for bold action. We can help people, we can change our system, and we can address inequities in one set of coordinated moves, but it has to be done at scale. To do this in a piecemeal manner risks just creating the fractured systems that we have. It has to be bold, and it has to be big, and it has to be something that will be transformative for everyone in this country so that they can all have access to the care they so richly need and deserve. Thank you.
Thank you so much, Dr. Carnick. So much appreciation. We had 3 outstanding presenters with us today, helping to frame this conversation and set our thoughts in motion vis-a-vis some of the recommendations and some of the opportunities moving forward. We do have time for discussion. And thank you to the panelists for sticking around for this. And first, we'll hear from Dr. Putnam and then Dr. Martinez. Please.
Thank you very much, Dr. Carnick. I'll let you get a drink of water here, but appreciate all the information that the 3 of you have shared. But one of the things that came up in our subcommittee discussion was focused on peer support. 1327. Apologize for the intercom. But the peer support that you had to be, if you haven't experienced what the frontline healthcare staff has experienced, or you haven't gone through high school without experiencing a lot of the key things that are so important in a high school or college year, that it's very difficult to relate to people. So we had a lot of discussions about peer support programs. Can you tell me how Focus or the CETA program would fit in from a peer? Is that something that fits into a peer support program, and how would that look?
So I think, Dr. Putnam, I think CETA would fit well in this regard. I would say Focus, we're at a more developmental stage in terms of testing that question. But certainly with CETA, Dr. Murray has done this with people with little or no education in other countries, have been able to be trained in this. And it's a manualized intervention. Basically, it kind of goes through step-by-step modules. And what they do is basically they sit down with the individual with the manual and in a guided way take them through it. And this is what would be kind of like the first tier of cognitive behavioral therapy interventions. This is not a full intervention that a professional would do, right? But this is, I think, an appropriate, if we have spent 30 years trying to expand the mental health workforce. I mean, and I want to support my colleagues and say that, yes, we definitely need more resources. We need more professionals, but I just don't see us getting to the endpoint where we have enough people out there and enough people with cultural knowledge of the local situations. So I think we need to kind of have this tiered approach where we would have lay people and peers in, doing this first level of support and being able to be in communication for supervision and for support and for training and for backup with professionals. Does that answer your question, Dr. Bottom?
Yeah, it does. It just seemed that people that have faced the kind of trauma that our healthcare workforce have faced will only share with people that have faced that. So
And the point is well taken. And so there are pockets of groups that where this type of system would not be appropriate. But if we think writ large across what COVID-19 has done, the amount of anxiety and depression and sleep problems that are out there, right? Some of those would be amenable to this, I think.
Well, thank you.
I guess I'm up, Madam Chair. Thank you, Dr. Evans, Akbar, and Dr. Karnik, great presentations. I think my question will go to Dr. Akbar. What I'd like to know is if you have any data or can share any evidence in reference to just the level of grief that our children are experiencing, and especially it's all children, because though it started with our losing a lot of our elders, a lot of adult parents have been lost to COVID-19, and they've lost one, and in some cases, some families have lost two parents, and these are leaving children with in a tremendous loss. I know of a family member, a friend of the family here in Central Texas, who in fact, he was in his mid-40s, who has passed away due to COVID, the breadwinner for the family, and he's left behind three small girls, three of his daughters. So imagine the impact that's having on just that one family. But do you have a sense, because I haven't seen any data, of how many children are being left without one or two parents due to this pandemic? And obviously, because it has hit our communities of color, our our American Indian, Latino, Hispanic, and our Black families disproportionately, I'm very concerned of the children of color who are being impacted by grief and the sequelae that happens based on the presentations you've all given. Could you comment?
Yes, thank you for that question. I think that the studies are still early looking at the aspects of grief and the impact to children long-term, and the number of losses that they have experienced, and then what does that really mean? But what we do know, and the statistic that I gave in terms of the overrepresentation of showing up in the ER due to behavioral health problems, is just one of the demonstrators that there is a significant mental health impact and effect that's happening on our children. And in particular, to your point, to Black and Brown communities. I think that, it is important for us to look at this, not just from a research perspective, but also to understand how are we going to deal with the impact of this loss and this grief long-term, knowing that the grief cycle is different for every individual. The process by which we grieve is different, and that we cycle through that grief in many different ways, and that the way that we demonstrate that grief can be very different. For some children, it will be them turning very angry. For some, it will be turning inward and feeling extremely depressed and dejected and disconnected even further than where they are right now. And for some other children, trying to figure out what a support system or support mechanism is going to look like. Just going back really quickly to Dr. Putnam's question, I think that this is where alternatives to the way that we're going to support our children are needing to be considered. Training community-based leaders like faith leaders and nonprofit leaders and mentors to be a supportive, person in the life of children that have had loss. And we know through mentorship programs that mentors can themselves completely change the trajectory of a child just by engaging in that special relationship with them. So, we are looking at that long-term, we're looking at the impacts of that long-term, and we know that there's an opportunity here to engage in prevention rather than waiting for the sequelae of the grief and the loss that has happened for many children and their families in communities of color.
Thank you so much. Please, Mr. Imperato and then Mr. Toronzo.
Thank you, Madam Chair. I'm Andy Imperato with Disability Rights California, and I am an adult who's been living with bipolar disorder my whole professional career. And I guess I was just wanting any of the speakers to comment on employment as a social determinant of mental health. Obviously, the pandemic has disrupted a lot of people's employment. and it's disproportionately impacted communities of color. So as we think about how to respond to the pandemic, how important is it that we build an inclusive economy and help people who've been displaced by COVID and the economic downturn get back into the labor market? And I'm just wondering if you can talk about the connection between mental health and work.
I can start. It's a very important aspect of our treatments for people who have mental health challenges. When you look at the research, about 80% of people who have serious mental illness, for example, would like to work, but only about 20% actually do work. So when I was commissioner, we were actively looking at ways to increase the amount of work that people would be able to do. The other thing, I think there's a couple of ways that we should be looking at this. So one is, obviously employment is ideal, but from a service standpoint, there are two things that I think we should be doing. One is we should be supporting supported employment, because we know for people, particularly who have very serious mental illnesses, it can be hard transitioning into the work world, particularly if they're coming from a very institutionalized kind of background. And so we know supported employment is a really important support for people. And it's one of the reasons that we really have to look at, we talk about flexible funding in our recommendations. We need to have more funding, for those kinds of services. Sorry about that. Perhaps somebody else can go. I don't know what happened to me.
Dr. Akbar or Karnik? Yes, Dr. Evans, you can take a moment.
Yeah, I can just speak to one example, Mr. Imparato. So, we are right now expanding our substance use treatment programs at Rush University, and with support from the state, we're going to hire 6 peer recovery support specialists. And one of the problems that has come up is that, we want to recruit people who have gone through this lived experience. Many of them have had contact with the justice system, right? And that ends up being a disqualifier for our HR department, right? And we're having to kind of work through that process with HR and say, look, they're at a point where actually their lived experience is really valuable to us. It's essential for us to have them on our team to help with the engagement work that we want to do. And this rule about this, as a general rule, may make some sense from a prior era, but in the modern era, the time from when they had that justice contact to now has been quite some time. The folks are in recovery. It's time to let them open a fresh page, right? And I think the stigmas of mental health and substance use are lingering in some ways, right? And that's what we see, in this impact. And we have the ability to make accommodations for people so they can continue to get care and continue to engage in their own treatment. To me, that's part of the richness of what we should be embracing in our care system, rather than trying to exclude people like that.
And if I could just add, half of the adults who lost their jobs related to COVID are still unemployed. And what we can't ignore is how terribly dehumanizing that can be to an individual who is trying to support their families, and how immediately that impacts their agency, their self-agency, their ability to feel resilient in a situation that seems completely untenable. And we also understand that it's also very difficult when you are in that situation to sort of think about what is the way out. How do I regain my standing? How do I regain, gainful employment for myself and taking care of my family? And then when the mental health issues set in as a result of that, right? This is a chicken egg question all the time, right? As a result of that, then how do I get myself out of this place where I'm, perhaps unmotivated, or I'm tackling a system that seems never ending in order for me to re-engage in it? So I think that is, I really appreciate, Mr. Imparato, the connection that you're making between employment and mental health, and the fact that we cannot separate these two experiences and challenges and act as if they're not interconnected and interlocked. a whole person experiencing an entire, issue that's devastating to their family.
If I could just finish, I apologize for that. That's never happened to me ever, but I guess it was first time for everything. What I was starting to talk about was flexible funding. And in some states, they cover what are called rehabilitation services or rehab option. But that should really be standard across every mental health system. It shouldn't depend on what state you're in terms of your access to those services that can help people get gainful employment. The other way I think about it is for people who are unemployed, we know that those individuals are going to have greater levels of distress, greater psychological distress, and we need to be intervening there. Again, not waiting until people cross the diagnostic threshold. So we're working with NIMH with a program for people who are unemployed to help them deal with that kind of stress level. So we really need to think about this from a whole population standpoint. And I think that the point about social determinants is really important. Getting a job can be much more impactful than a 50-minute psychotherapy hour or multiple 50-minute psychotherapy hours. And I think the more we recognize that, and that's why we talk about a whole government approach, we have to deal with those other resources that can have a profound impact on people's mental health status.
Thank you. Mr. Toronzo?
Thank you, Madam Chair. I just want to go ahead and thank first Dr. Karnik, Dr. Akbar, and Dr. Evans for giving these excellent presentations. We really appreciate hearing your input on this topic. Obviously, as a young person, I have a personal connection to what I've been hearing amongst how young people have been struggling. It really hurts to hear on how many young people have been really suffering and struggling with their mental and behavioral health this past year. You know, the CS Mott Children's Hospital at the University of Michigan reported that almost 75% of parents reported that COVID-19 had a negative impact on their children when it came to their ability to interact with their friends, which obviously due to social distancing and other factors, but almost 50% of parents within this polling said they had noticed a new or worsening mental health condition for their teen since the start of the pandemic. But something I'm not sure if any of you have seen the data, I'm sure you have. This past year during the pandemic, 2020, suicide rates decreased. But something that shocked me was how amongst Black youth, suicide rates shot up. So I just wanted to know if any of you had some sort of analysis or explanation as to why this may have happened during the pandemic.
I can start out if you like.
Okay, go ahead.
Dr. Evans, you want to go first? It's fine.
No, go ahead.
I'll put my hat on as a child and adolescent psychiatrist now, and you know, so to say that I think, you know, the dynamics around this are very complicated. It's hard to kind of put a generalized pattern over everyone when we look at this. So you were pointing to the data that, you know, the vast majority of the families said that, you know, the stress levels had increased, right? And it's been harder for their children. I have there's also compelling data, and I've talked to some of the families for whom there were children who were, you know, victimized and bullied prior to COVID in schools, you know, LGBTQ children. There are children with autism and neurodevelopmental disorders that are disproportionately victimized, right, in school settings. I'm hearing from some of the families that I work with that those children actually did better in this situation, right, than you know, the vast majority of other children who were suffering, right? And I think the dynamic you're pointing to with Black youth who had increases in suicide versus decreases in suicide in other areas, right, points to some of those dynamics, that these are pockets of stressors, and they're inevitably what Dr. Evans pointed to earlier, right? These are structural racism, social determinants of health, likely driven dynamics. right? And we won't know the full extent of how these things unfolded for some time until we can unpack it. But when your community's under stress and people are losing jobs in the settings where you're in, it comes to me as no surprise that there will be pockets where subpopulations have been suffering. And that's why I think it's important to do exactly what you did, is to look beneath the overall data to look at those subpopulations, because we often miss them.
Great, thank you. All right, Dr. Khaldun, please, and then Mr. Watts.
Thank you, Madam Chair, and thank you to all of our presenters. I have a question for Dr. Karnik, and very intrigued by CETA. Can you talk a little bit more about kind of what that looks like on the ground, and also perhaps any differences between that and mental health first aid?
A great question. Thank you for that. So what it looks like on the ground is, having dedicated time to train people, and the CETA team has worked hard to make their training really, time efficient and capable. And then there's ongoing supervision for the folks who are doing the treatment, and so it is really bringing them into that space. The way I would say it's distinguished from mental health first aid is mental health first aid is really a very good intervention, and it is well proven to work in stigma reduction, but it is not a treatment in and of itself. I'll defer to my colleagues, Dr. Akbar and Dr. Evans, if they disagree with me, but I don't think mental health first aid really has the impact clinically that we want to have, whereas CETA actually has proven outcomes to addressing anxiety, depression, substance use, across these multiple domains. And it really is, it isn't rocket science, right? This is CETA draws from, many years going back to Aaron Beck and the development of cognitive behavioral therapy, right? It is basically modules of cognitive behavioral therapy that are simple enough that people with limited training could do it. It's not the full package, right? And similarly, I would say that mental health first aid is like the first level. You want to reduce stigma and have psychoeducation, but then this would be the next tier up from that. Yeah.
Thank you. Mr. Watts, please.
I want to thank for the excellent presentations, and I really appreciate the attention that was also given to substance use disorders, which I always fear is going to be overlooked when we talk about behavioral health. So I have a question. Harm reduction is an evidence-based practice, and that has been useful across health conditions. And I'd like to ask, when we talk about substance use disorder, what is your, where does harm reduction fit in your philosophy or in any of these models?
Yeah, I can address that. I think that harm reduction is a part of a good comprehensive approach to substance use. I think the reason that it has gotten a bad name in the field is that some people believe that harm reduction is just letting people do whatever they want to do, and in terms of facilitating and promoting use. That's not the way I look at harm reduction. Harm reduction, in my view, is still about, the ultimate goal should always be about long-term recovery for people. And there are always a group of people who are having a very difficult time. They just haven't made up their mind that they want to quit using, or they don't have the ability. In the meantime, it's important to keep those people alive. It's important to help protect their safety. And when I was commissioner, we had programs where people could go, especially in northern cities. People can literally die if they're on the streets and they're actively using it. But they could go to these programs. There wasn't a requirement for them to not be using when they came into those shelters. And that kept people alive. But while people were there, we engaged them and tried to engage them in getting into longer term treatment. So I think it's the sort of the mindset you have. If harm reduction is, well, we're just going to have a place for people to come and hang out. That's not my idea of harm reduction. Harm reduction is, let's keep people alive, and then let's engage them, because the ultimate goal is to make sure that they get into long-term recovery.
And if I can add, Mr. Waz, one addition to that, I agree with everything Dr. Evans said in terms of harm reduction. I think harm reduction is also a perspective where you're meeting the patient where they are and taking that as a starting point, right? Rather than trying to dictate to them that this is how it's going to be, right? You're really trying to use those engagement strategies. And I also think it is about moving, drug and substance use treatment from a criminalization standpoint into a medical and treatment standpoint, right? That we want to engage with you to get you better and really work with you where you are. And it incorporates housing, it incorporates jobs and employment and education. All of these components come into what I think of as a comprehensive harm reduction approach.
Thank you.
Thank you. Just so mindful of the time, Ms. Turner, I will ask you to make your comment, and then Mr. Joseph, you, and then we'll give our panelists a chance to respond to both of those before we break. Ms. Turner, thank you.
My question is for Dr. Karnik. I've kind of heard you say that in the realm of behavior and mental health, we need a new day, that the old traditional is not working. Well, part of the new day needs to be, and I want to know what your thoughts on this, what are some of the long-term solutions to training more people of color to be psychiatrists and psychologists, so that these populations have people that are culturally competent to take care of them when they need them. I hear you saying that telehealth and community health workers who can motivated to be trained in these professions. I've heard you say that, but are we saying we're going to just settle for telehealth and these kind of things, or are we going? Do you have some long-term plans or some suggestions to solve the other part of the puzzle?
Thank you, Ms. Turner. Well, one second, Dr. Karnik. We're going to get to comment from Mr. Joseph just for time, and then we'll allow the panel to answer both. Mr. Joseph, please.
All right, thank you. First of all, I'd like to First of all, I'd just like to thank all three of the presenters as they're moving forward. Early on, we had Dr. Evans talk about the impacts that COVID-19 has had on certain communities and talked about the negative consequences, along with the violence. There was suicide, violence, and other areas, and that you were seeing increase in certain population. My concern as this was happening is the underreporting. I have spoke to a number of police officials here in my hometown, and they were saying the numbers were lower, but I know personally that a lot of people are not reporting. Following that up was just the data gaps. As you were looking at it, Dr. Akbar, you were talking specifically about those factors that impact social well-being or well-being, and the data gaps that you were really concerned at as you were doing your analysis. Dr. Karnik, just really appreciate you bringing up peer support, as we see that as a real major factor with the criminal justice. If they have any criminal justice history at all, or minimal criminal justice history, that could create barriers for opportunities and jobs and basically impact the service delivery. So thank you for bringing that up. Madam Chair.
Thank you so much, Mr. Joseph. So if we could get final thoughts from our outstanding panelists, first to you, Dr. Karnik, and then to Dr. Evans, and then Dr. Akbar, you get the last word for us.
Mr. Joseph, thank you for your comments, and I appreciate that. And so, Ms. Turner, I appreciate your perspective, and I think I fully agree that we want to expand the professional, cohorts and welcome in more individuals. Honestly, this is part of what I work on almost every day here. I have been pushing NIDA and the National Drug Abuse Treatment Clinical Trials Network to expand training pathways. I am submitting these grants and to build this. I will say that I think focusing exclusively on MDs and PhDs, and I'm guilty of having both, right? Is I think a narrow perspective for this. I have been recruiting people to my team to get better representation. My deputy is a nurse practitioner who is amazing. And so we have to really think about not only increasing opportunities for people to go to medical school or graduate school, but recognize that going to medical school and graduate school requires resources. And if we only let those people do certain functions, then we are kind of reifying the structural racism that exists, right? So yes, we need to expand those opportunities, but we also need to think outside the box a little bit here. And what I have told the Clinical Trials Network is that, you know, we should be welcoming nurse practitioners into our cohorts and training them to become clinician researchers and leaders, because nursing and social work are some of the pathways that often people from underserved communities have more access to. It's a more, you can go and get your RN or your LVN as a first step into the profession of nursing, right? Whereas going to medical school requires a big leap of time and resources. So I think we just have to acknowledge that that's part of the reality, and then bring all of these professional groups along in a way that allows us to diversify our workforce from multiple approaches.
Thank you, Dr. Evans.
Sure. What I would say, again, thank you for allowing us to come here and speak. One thing that Dr. Karnik said that I absolutely agree with, and I actually had it in some of my notes, is that we have to be bold at this point. We had structural problems before. And in fact, the same arguments that we've made today in terms of moving to a population health approach, we were making those arguments before COVID, because of in large part because of the inequities, but in large part because there are many people that we're missing, because we have a passive system where we wait for people to come to us when the problems are in the community. Most people who have behavioral health challenges are not coming to treat, they're not knocking on the doors of treatment programs. And that is particularly true for communities of color. So if we're going to have any shot at dealing with the magnitude of the problem that we have to radically change the paradigm. That's why we believe that we ought to be thinking in terms of how we get to high-risk groups in our communities. How do we get to people who are relatively healthy and keeping people healthy? We don't have a funding structure today that allows us to do that. You're going to be speaking to the president. And my strong recommendation is that we have to change how we think about mental health and substance use, and use the same strategies that we use for physical health. We have a whole public health infrastructure in every community in the nation to make sure that fewer people get ill. We have practically nothing for people who have behavioral health conditions. And so our strong recommendation is that we have to change the paradigm. We have to have resources that allow us to work upstream, allow us to address social determinants, and allow us ultimately to engage communities in ways that we have not historically done that. And in my own career, I've seen that when you do that, and you do the kinds of things that Dr. Karnik was talking about, that it makes a huge difference in reaching people who are otherwise missed by our mental health and behavioral health systems.
Right. Thank you so much, Dr. Evans. Dr. Akbar, please.
Thank you so much, Dr. Nunez-Smith, and thank you to Secretary Levine and the task force members, Mr. Joseph, for your comments about aggregating data, the importance of that in order for us to be able to make systemic changes. I want to address Ms. Turner's question, and I have some very specific recommendations that I'd love to make. You know, in order to get more people of color in psychology and psychiatry and in the mental health field, we have to begin by providing federal funds for scholars and scientists of color to conduct the appropriate research on racial trauma, healing, and other aspects that affect communities of color. We have to have funding pathways to programs for diverse psychologists that give opportunities, such as the Minority Fellowship Program. So when appropriations is thinking about this and how to support graduate programming, this is one of the programs that has been significant in terms of impact and pathway development. We have to provide funding for diverse-led organizations that work on healing and building strength building and capacity building in communities of color. And we also have to have rigorous applications and metrics for accountability around the distribution of funds. Where are these funds going? Are they going to psychologists and psychiatrists and mental health providers of color that are able to engage in the scientific work and are able to engage in the work of clinical practice? And lastly, we have to be able to change the lens by which we see communities of color, looking at their resiliency, looking at the way that they can be empowered, and looking at the ways that they can be strengthened is one of the vital areas that being a provider of color allows you to engage in that type of empathy and compassion and empowerment for communities of color. So I really appreciate that question and you lifting that question and that being the last question that we leave on for this conversation.
Great. Thank you so much on behalf of the task force. Thank you to Drs. Evans, Dr. Akbar, and Dr. Karnik. Really stimulating, important discussion that we just had. For the team, the time is now 3:30 Eastern. We will take a break and we will rejoin at 3:35. Thank you so much, everybody. Thank you again to our speakers. Phenomenal. Thank you. Okay, wonderful. As we regather, just a reminder that next up on our agenda, we have a chance to hear from our onboarded federal ex officio members by way of introduction, and then we'll be turning to the subcommittee recommendations. In between, Dr. Wendt will revisit the roll call, make sure that everyone is here and accounted for. So, Ray, one of the wonderful things I think about this task force is that we are able to have both federal and non-federal members working together so closely in subcommittee, and of course here in the full task force meeting. So it's I think important moment for us to pause right now and get to hear from those new members. I'll just ask you to briefly introduce yourself, just your name and your agency, and if there's anything in particular you want to say about how your work might be connecting with the task force. If Dr. Bleich is on, let me ask you to start. Oh, there she is.
I'm
Welcome.
on. Thanks very much. It's great to meet you all. Sarah Bleich, Senior Advisor for COVID in the Office of the Secretary at USDA, and I come at this from a public health background. I was previously at the Harvard School of Public Health. Very much looking forward to working with all of you on the task force.
Welcome. Dr. Kardashian.
Great, thank you. Jessica Kardashian with the Department of Education in the Office of Planning, Evaluation, and Policy Development. And I think we can see from the previous conversation the impact that this work has, not only on students, but also on educators as well. And really excited to be part of this work. One thing I will highlight is that we've been releasing data on students' return to in-person instruction and are seeing the disparities among students of color returning at lower rates, and are really committed to understanding why students of color are not returning at the same rates and what we can do to increase their return rates, and feel wholeheartedly that the work of this task force is very much tied to that work as well. And so thank you for the opportunity and for the presentation so far today.
Thank you, welcome. Ms. Hanks?
Hi there, I'm Angela Hanks. I'm a counselor in the Secretary's office at the Department of Labor. I'm on this task force, I think in part because the Department of Labor is very interested in the welfare of workers and the health and safety of workers, and certainly the disparate impacts of COVID-19 on the workforce, particularly for workers of color, has been really devastating in terms of folks' ability to earn wage, to be employed, to be safe at work. And so I'm very interested in all of those questions.
Thank you and welcome. Mr. Nguyen.
Here, Eric Nguyen from the Department of Justice. I am a senior counsel in the Deputy Attorney General's office. Really honored to be participating in this with everybody. The department right now has an important role to play in criminal justice and looking at disparities and inequities in that system. And also COVID specific has a lot of people in its care in the Bureau of Prisons and who are in the custody of the Marshal Service. And so this work is directly relevant to them. I can say as somebody who's has been a career prosecutor and is sometimes in the trenches of the day-to-day focused on, what's the next case, who's the next victim to talk to, the next defendant's case who's up in court. It's sometimes easy to forget that we need to take a step back and think about systemic problems. And I think one of the benefits here is in the course of all the day-to-day, how do we deal with COVID and sort of the day-to-day management of the problem, we take a step back and think about what this reveals about bigger problems when it comes to healthcare and how we solve those problems together. So I think this is a great opportunity, and thank you for all your input too.
Wonderful, welcome. And then Dr. Levine.
Well, thank you. I've had the opportunity to address the task force a couple of times. I'm Rachel Levine, the Assistant Secretary for Health. The one thing I promised yesterday that I would mention is I had the opportunity to go to Philadelphia yesterday, and I spent some time with Dr. Stanford and the Black COVID-19 Consortium. And Dr. Stanford, if you don't know her, is a rock star, and she's been working on health equity with COVID-19 for the last year, and she is doing just such a fantastic job with vaccinations now for the African American community and other underserved communities. So I promised I would mention it, and there you go.
Thank you so much. Great, and welcome again. We're just so thrilled to have all of you on board. Thank you. At this point, I'll pause and pass it to Dr. Wendt to a second roll call, please.
Thank you. Even though we just heard from both of you, but I would like to do the roll call again for official record. Ms. Angela Hanks.
Present.
Mr. Eric Nguyen.
Present.
Thank you. Back to you, Madam Chair.
Thank you, Dr. Wendt. All right, so the teams have all been so hard at work, and at this point we will have a chance to hear from each of the subcommittees and discuss the interim recommendations specific to behavioral health. Dr. Okafor, thank you so much to you and your entire team for the work. I turn it over to you.
Thank you, Madam Chair, and I want to thank everyone. This has been a remarkable and esteemed members of the task force, and they have done amazing job, as you will see. What you're seeing on the slide for those who are watching or those listening is basically what the Madam Chair had already explained, which is the executive order and the mission of this task force. For those that joined us later, I just wanted to reiterate that the executive order actually is for recommendations to be presented so that we can mitigate the health inequities caused or exacerbated by COVID pandemic, and also to present recommendations on how do we prevent such inequities in future as we prepare the nation in terms of responding to any future pandemic. There are 4 subcommittees that we have. So the members of the task force make up these 4 committees, and you will hear from them later on, but I'll mention them briefly. We have our structural drivers and xenophobia subcommittee. We have our data analytics and research subcommittee, and we have also collaboration and communication subcommittee, as well as our healthcare access and quality. The work of this executive order is being done at the subcommittee level, and these subcommittee members have worked tirelessly. When we said intensely, I just want to give you a little breakdown of what we meant by intensely. So each of them actually meet every week. Not only 1 meetings, but they have more than 1 meeting that they do have, and each of the subcommittee review evidence around the topic area. This month is on the mental health and behavioral health related to COVID and the inequities surrounding that. And we want to thank a lot of people that put their efforts towards creating those evidence and literature searching, especially our interns who are listening, and we just want to do kudos for all the work that you put into this. And then we also have the subcommittees meeting in between to really listen to a lot of the subject matter experts. And Katie will show some of the subject matter experts that they've met. These experts actually help to contextualize some of the information where they wanted to go deeper. And then they also, after that, sit down to contribute across subcommittees, because they are all members of one task force, even though they go deeper and dive in based on their subcommittee impact areas. And at the end of all this, they provide remarkable recommendations, which they will be sharing soon. Next slide, please. So I'll get to just highlight a few of these recommendations, and then I'll turn it over to the chair, because it's better for you to hear from them and really see the exceptional work that the subcommittee members have put forward. So there are 4 themes that we are able to extract from all that you will hear. The first is around data collection, harmonization, and the integrity of data, so that we make sure we are able to really figure out where are we with the inequities, and then who are experiencing those inequities, and what do we need to do, by whom, when, and where, in order for us to address them. So the data play a critical role And one of the highlights I will mention is really the idea of having a comprehensive data, standardized data relating to mental health and substance use disorder and the inequities around that. The next theme I'll mention quickly is the theme across surrounding the increase in access to mental health services, as well as substance use disorder services and intervention in marginalized communities. This theme came across the 4 subcommittees, and I'll just quickly highlight one of the elements that you will hear more when the chairs will present their work. And that is in the area of increasing diversity of behavioral health providers and clinicians so that we can increase not only access, but increase quality that builds on trusting relationship between the clinicians and the people and the patient, as well as actually looking at how do we address crisis during emergency, in addition to providing other intervention relating to behavioral health needs of the community. Next slide. Thanks. So 2 themes that I'll highlight will be engaging the community. And this theme, is really around how do we build more awareness, but not only awareness, but engaging and partnering with the communities, because most of the issues are happening on the ground, as well as solutions that will be meaningful and responsive will have to be culturally aligned to what is happening in terms of realities of the members of the community. And then we talk about the impact of this COVID pandemic on working families. And the chair will present about the syndemic component of this COVID pandemic as it relates to other social determinants of health, which includes the housing, the food, nutrition security, job security, and other related issues. So having given you a preview based on the themes of what you will hear, I would like to introduce our first subcommittee, and I'll call upon the structural drivers and xenophobia, and I will turn it over to Hye Young-Yoon.
Thank you so much. As noted earlier, the task force is responsible for making recommendations for mitigating health inequities caused and exacerbated by the COVID-19 pandemic and for preventing such inequities in the future. This subcommittee of xenophobia and structural drivers of health inequities is charged to identify actionable recommendations to address the rise of xenophobia, especially against Asians, Asian Americans, Pacific Islanders, and Native Hawaiians during the pandemic, and other systems and policies that have contributed to or exacerbated COVID-related health inequities, especially for marginalized and underserved communities who've been hit hardest by COVID-19. In identifying our recommendations to address structural drivers of health inequity, we looked at the social determinants of health and well-being, like safe housing, transportation, employment, income, nutrition, to articulate the problems we're seeing across different communities and recommendations to address such problems. For this month's topic of mental and behavioral health, our subcommittee identified 6 problems and ensuing recommendations. The first problem goes to xenophobia. Excuse me. Sorry, I was having a little bit of a trouble. The first problem goes to xenophobia, making a direct connection between the rise of hate crimes, acts of discrimination against the diverse Asian Pacific Islander community, and negative impact on their mental health. The rest of the 5 problems speak to structural drivers. The second problem, which is the first of the 5 structural drivers, speak to economic insecurity and how such instability is affecting people's mental health. The third problem makes the connection between housing insecurity and mental and behavioral health. And the fourth problem speaks to the pervasiveness of racial and ethnic inequities in our mental and behavioral health system, even before the pandemic, and how such inequities have been exacerbated in the midst of pandemic. The fifth problem speaks to the criminalization of behavioral health issues when there should be better and more appropriate access to treatment. And this, lastly, the sixth speaks to food and nutrition insecurity and its impact on mental and behavioral health. So before, Martha, I'm so sorry. I apologize. I'm having a very bad attack of hay fever today, and I'm a little bit drugged out, so apologies. I should have introduced the members of our subcommittee. So could we go back to that slide? So the members of the subcommittee are Myra Alvarez. Let me first go through the members of the task force, and then ex officio have joined us. But Myra Alvarez, Victor Joseph, Octavio Martinez, Mary Turner, and Bobby Watts. And we were really thrilled to be joined by Sarah, Angela, and Eric. So I'm gonna first, if we can go back to the problem statement 1, what I'm gonna do is talk about actionable recommendations for each problem. And then after I'm done, I'm gonna see if the members of our committee wants to address. So in terms of the first problem, this is really speaking to the rise of hate crimes and acts of racial discrimination and bias against the diverse community of Asian American, Pacific Islanders, and Native Hawaiians, right? And its negative impact on their mental health. For this problem, we have identified 3 recommendations. The first one is for the federal government to increase federal funding to organizations that work directly with survivors of violence and groups that create community-driven solutions. The second recommendation is for the government to play a role in strengthening anti-discrimination protections for the community and support investigation and prosecution of hate crimes, including the most recently passed federal legislation that is addressing to strengthen the prosecution of hate crimes. And lastly, the federal government should play a role in promoting inclusion of histories, cultures, and experiences of this diverse community into school curriculum at all levels of schools, whether it's elementary school or colleges and universities. So let's go to problem number 2. Problem number 2 is what we've been talking about in terms of the economic insecurity due to the sudden job losses, reduced work hours, working under hazardous conditions, and especially in this moment when there's been such financial insecurity that the immigrant communities, especially those members of the communities who lack legal status, have been feeling the increased vulnerability. So all of these precariousness they are experiencing related to their jobs and economic stability have all contributed to increased stress and anxiety, again, affecting their mental health of workers and their families. Here again, we have 3 recommendations. The first is the government to work with Congress to pass the most robust jobs and economic recovery plan to ensure that all working families can earn family-sustaining wages, have access to benefits like health insurance, paid time off, strong worker protection, so that they have a real shot at economic security and opportunity. And the second is the federal government to directing the Department of Labor to issue the emergency temporary health and safety standards to protect workers from hazardous COVID-related working conditions. We know that President Biden very early on in his administration issued an executive order directing the Department of Labor to do so, but by March 15th, that deadline has come and gone. So we're re-urging the federal government to work with DOL to issue this very important standard. The third is the government to increase funding for worker protections to federal labor and employment agencies so that they have sufficient resources to protect workers from hazardous and substandard working conditions. Can we go to problem 3? So problem 3 is really addressing the housing insecurity in both urban and rural America and the negative impact that has on communities due to that, again, insecurity and precariousness. The stress that comes from eviction, sheltering in a home that with poor conditions or in crowded conditions, right? And to really thinking about how do we create a more safe housing situation, to result in a better mental and behavioral health. So again, here we have 3 recommendations. The first recommendation is for the federal government to continue funding housing assistance, including renewal of eviction moratorium. The second is to continue to support quarantine shelters to prevent the spread of coronavirus to people living in congregate housing, those who are in homeless or in multi-generational housing. The last recommendation applies to families in public housing, that the federal government should prohibit local public housing authority from disqualifying individuals from eligibility for the housing vouchers on the basis of criminal drug history. Can we go to the problem, the 4th problem? The problem number 4 is really talking about the longstanding inequities that existed before the pandemic in our health and behavioral health system, and how the COVID pandemic has exacerbated those inequities. Here we have 4 recommendations. The first recommendation is what we've been talking about earlier with our invited presenters in terms of the federal government increasing funding and the support for the development of diverse mental health workforce to contribute to more racially, ethnically, and culturally targeted access to health and behavioral benefits, and also to fund to support rural community that include clinics, treatment centers, rural hospitals, mobile health vans, in order that they also thrive and prosper. The second recommendation here is to develop public awareness campaigns focused on increasing knowledge of mental health, substance use disorders, and partner with diverse stakeholders, schools, agencies, community groups, in order to reduce the stigma of mental health. The 4th is connecting it to the access to affordable broadband internet access to low-income rural communities so that they have different ways to access telehealth, telepsychiatry, and other supports. And lastly, the last recommendation is focusing on increasing funding to tribal early childhood programs with culturally and linguistically competencies needed for their well-being, really looking at the needs of the Native communities. Can we go to the 5th problem statement? So this is really talking about that in our current system, those struggling with substance abuse disorders or mental illness too often face criminal or disciplinary consequences when they should have better access to treatment. Here we have 4 recommendations. The first is to shift responses to mental health crisis from disciplinary responses or law enforcement responses to community-driven, health-oriented crisis responses. Connected to that is developing alternative responses to police responses, and by addressing both the psychological and medical issues that they need and assess in order for them to access the benefits. And lastly, it is to enact health insurance payment policies for substance abuse treatment. So our last problem is related to problem in terms of the food and nutrition insecurity. That food and nutrition insecurity remains a significant problem that is made worse by the COVID pandemic. Here we have 6 recommendations. First, to build a strong, more resilient nutrition safety net to better prepared to protect our most vulnerable citizens generally now and against future pandemics and other unforeseen circumstances. Second is to leverage technology to maximize participation, retention of people accessing federal nutrition assistance program to create a hassle-free system that provide more convenient access. The third is to expand access to healthier food, beverage choices across the nutrition assistance programs. The fourth recommendation is to expand access to online grocery shopping, especially for program participants in areas with limited access to healthy foods, areas of food deserts, grocery deserts. The fifth is to strengthen local and regional food production by providing flexibility of production and distribution. And lastly, it is to recommendation that is targeted to regions like Alaska and other regions where the increased cost of merchandise and freight due to the pandemic and making it difficult for them to access food. And in such cases, to authorize hunting and fishing openings to compensate for hardship brought on by this pandemic situation. So I'll stop there and see if other members of the committee want to add anything I missed.
Ms. Turner, please. Thank you. Thank you. Thank you so much, Chair.
Thank you. I want to talk about why the OSHA emergency standard that fully recognizes that COVID-19 is an airborne transmissible disease is both an equity issue and a mental health issue. Fully recognizing that the airborne transmission of COVID is an equity issue because essential workers are disproportionately people of color, especially women of color. And if we can admit that if this is airborne transmission, this would ultimately mean that higher levels of protection would be required. And numerous studies have also shown that essential workers are more likely to experience stress, anxiety, depression, and insomnia because they lack sufficient personal protective equipment. And that this keeps themselves, this makes them more likely to be infected with COVID and more likely to cause them stress because they don't feel protected at work. We have examples of nurses and other healthcare workers and other essential workers that are still not being, are still reusing respirators and that are designed for only one-time use, and that are just getting surgical masks, which are only, block about 3% of the COVID virus. Even though there are respirators that are sitting in warehouses unused. And lastly, I'd like to say that this OSHA emergency standard, from someone who's on the front line and who represents the workers, all workers, we needed these standards a year ago, but we will be overjoyed to accept them today. Thank you.
Thank you, Ms. Turner. Mr. Joseph, please.
Thank you. If we can insert substance abuse on problem 4, item 1. And just for purposes where I won't have to continue to go in here, Madam Chair, I feel it's important wherever we have mental health and we can add substance use, or substance abuse, or substance disorders into the presentation or into the document throughout it, so I won't have to keep on coming back. So with that, I'll just ask that we make that amendment and move forward so we can just be more inclusive. I think it lays right in line where Bobby Watts was talking about don't want substance abuse being an afterthought.
Thank you, Mr. Joseph. So that friendly amendment is well noted. We will default to the behavioral health frame, which includes issues of mental health as well as substance use disorder in all of the recommendations. Thank you so much, Mr. Joseph. Chair Yoon, is there anything else you'd like to add? I do not see hands from any of your other subcommittee members, I think. So then with that, we could open it up to the full task force. Yes, Chair Yoon. Thank you, Dr. Khaldun.
Yes, wanted to really thank the subcommittee for this important work. I wanted to take note of the problem statement 6 on food and nutrition insecurity. Really, really important. But I wanted to emphasize the comment about leveraging technology and streamlining systems so that people can get enrolled. I think it's not only about technology, but it's also about the systems. And when families are touching and interacting with the systems, literally in a clinic, enrolling in these programs, then we need to think about the people and the infrastructure in addition to the technology. I've done some of that work at the local and state level, and I think it's really, really important.
Thank you so much, Dr. Calhoun. No, would you like that included as considered as a friendly amendment for language regarding workforce?
Yes, I think it's about cross enrollment and just beyond technology, but I'm happy to follow up about specific language.
Thank you so much, Dr. Khaldun. Dr. Hildreth, please.
Thank you, Chairman Nunez-Smith. I want to take this opportunity to add my voice to what Mary Turner, my colleague Mary Turner, has said. SARS-CoV-2 is an airborne pathogen. It needs to be recognized as such. And the people taking care of the folks who are hospitalized are taking care of people who are primarily from disadvantaged populations. So by extension, equipping those people with the things they need to protect themselves is in fact an equity issue. But I just like to say, as someone who studied viruses for 40 years, all of them that are pathogenic, this is an airborne pathogen and it's time for it to be recognized as such and appropriate actions taken. That's all I want to say. Thank you.
Thank you so much, Dr. Hildreth. Dr. Martinez, did you have a comment? Thumbs up. All right, got it. Thank you so much. All right. Any additional comments regarding the interim recommendations put forward by Structural Drivers and Xenophobia Subcommittee at this time? We'll have a chance to return to deliberation before we take up voting. Okay, wonderful. All noted. We'll ask the subcommittees again to consider the issues that have been raised so far in the discussion. Dr. Okafor, please.
Thank you, Madam Chair, and thank you, everyone, especially our task force members from Structural Drivers and Xenophobia. Ma'am, we are going to introduce the next subcommittee, and that is our Data Analytics and Research Subcommittee. And I would like to call upon Dr. Janet Khaldun, who is the chair, and you will listen to really exceptional work that they have done and the recommendation they will bring forth. Dr. Khaldun.
Thank you, Dr. Okafor, and thank you for the opportunity to present our subcommittee's interim recommendations. I want to specifically also recognize our amazing subcommittee members, Dr. James Hildreth, Andy Imperato, Victor Joseph, and Dr. Homer Venters, but also really the entire task force, HHS staff, and our interns for their real thoughtfulness and attention to this very important work and topic. And of course, also reiterating our thanks to our subject matter experts who took time out of their busy schedules to speak with us. So next slide, we had 3 key recommendations for this topic. The first one is that there's really limited data on the scope and drivers of the disproportionate impact of COVID-19 on mental health and substance use disorders in all communities, particularly those who are marginalized, minoritized, or medically underserved. So this would include racial and ethnic minorities, LGBTQ populations, Native, tribal communities, people living with disabilities, youth, those experiencing homelessness, the justice involved, elderly, and people who are living in remote or rural communities. Our next problem statement speaks to the fact that there are limited data on COVID-19's impact on people who have co-occurring disorders, substance use disorders, or who overdose, and how COVID-19 may have actually widened the disparities there. And then finally, our last problem statement. There have been many policy changes made in the context of COVID-19, but there's limited analysis or evidence on their impact within that specific context. So this includes expansion of telehealth services, criminal justice, and also some housing policy changes. So I'm going to talk a little more about our recommendations for each problem statement. If you can go to the next slide. So to address problem statement 1, we actually have 10 recommendations. The first one here is that the federal government should collect, integrate, and share data related to mental health and substance use disorders and COVID-19. So this would include, but not be limited to, data on testing, hospitalizations, prescriptions, and utilization of community-based therapy. Importantly, I think this is an important theme, this data would also be disaggregated and used to guide improvement and expansion of mental health and substance use disorder resources. We also thought it was really important to include reporting through the National Notifiable Diseases Surveillance System and the CDC National Vital Statistics System here. So our next recommendation for this problem statement is that the federal government should support a study on the drivers of depression, increased substance use, and suicidality, and the widened disparities that have been identified and discussed earlier in this meeting during COVID-19. We also recommended the importance of engaging community members and people with lived experience in understanding data on mental health and substance use disorders, and also importantly, developing and implementing solutions to address them. I really appreciate the remarks from, it was Dr. Evans from the APA who spoke earlier, who said, inherent in every community is the wisdom to solve its own problems. That is so important. It's important for all things in public health, but especially when you're addressing equity. And so this recommendation really does speak to that. And we also specifically support the use of a community-based participatory research framework here. Our next recommendation is about expanding sample size and oversampling specifically in public health data systems, really, again, getting to the importance of disaggregated data and helping to drive and understand these issues for specific subpopulations. Our fifth recommendation is that the federal government should convene an interagency work group or group that promotes and aligns the collection, reporting, and sharing of data to really understand and drive responses to prevent and treat substance use disorders. So we also think it's important that this data is linked to understand the association between substance use and mental health disorders, but also, again, a theme of this conversation, social determinants of health. So things like employment, housing, access to quality treatment, social supports, and also income and educational attainment. Our sixth recommendation, I think this might be on the next slide, here we go. The sixth recommendation is that the federal government should implement a robust analysis of the impact of COVID-19 on the mental health of all communities, and specifically subpopulations, and we're going to keep reiterating this, but youth, healthcare workers, which we've talked about a lot, elderly, racial ethnic minorities, people who are incarcerated or otherwise minoritized or marginalized. We also really think it's important to understand the intersectionality across these different groups, which may actually compound and worsen these adverse impacts. Our seventh recommendation for this problem statement is that the federal government should really issue guidelines and provide resources to implement widespread mental health, substance use disorder, and interpersonal violence screening in a wide variety of settings. Again, we talked about this a little earlier with our presenters, but systemic screening and referral processes really should be put in place, and they should leverage and expand and improve upon the existing healthcare infrastructure, and should also be culturally and linguistically responsive. Our eighth recommendation, the federal government should expand incentive programs to improve surveillance and collection of data in public and private behavioral health services settings, including psychiatric hospitals, carceral settings, outpatient settings, of course, as well. And this includes incentivizing the adoption of electronic health records. We also thought it was really important, recommendation 9, to improve the collection of data on the mental health of Asian American and Pacific Islander and Native Hawaiian communities. And then finally, our last recommendation for this problem statement, really emphasizing the importance of security and privacy for all data. So for problem statement 2, the next slide, we had just one recommendation here, and that was that the federal government incentivize research on the impacts of COVID-19 on substance use disorders and co-occurring disorders, and really here emphasizing including polysubstance abuse, the use of stimulants. Again, it's not always opioids, it's the use of stimulants. Alcoholism is still a challenge, and also how these disorders have really impacted marginalized and minoritized communities. On the next slide, for our third and final problem statement, we had 3 recommendations. One is that the federal government should support an analysis of the many policy changes during the pandemic that have expanded access to mental health and substance use disorder treatment. So recognizing that there is an evidence base and there was an importance, there's a need for this to be expanded, but really doing a deep analysis of that expansion. We also recommended supporting an analysis of the impact of expanded telehealth services in the context, again, of the pandemic, recognizing there is a strong evidence base for telehealth, but also really wanting to understand the successes, the lessons learned, and potential gaps identified during this pandemic. That would be really important. And then finally, there should also be an analysis of other policies that involved housing, criminal justice, Medicaid, and there are many others during this pandemic, so we can really understand the outcome of those and where there may be gaps and opportunities to even improve and expand. So that is it for our recommendations. I'd love to open it up to my subcommittee members if they have additional comments to make. Andy, am I calling up? Oh, sorry.
My apologies. I think I was loaded into the unmute. Thank you so much, Chair Khaldun. Much appreciated. I was just cross-checking in terms of those members. So first, Mr. Imperato, and then Dr. Venters, please.
Yeah, thank you. First, I just want to thank our chair, Dr. Khaldun, for her leadership, especially when the state of Michigan has really been struggling with COVID. I just really appreciate the amount of time that she's put into this while she does her full-time job. One thing I wanted to mention is sometimes in research, we think of disability as an outcome and we don't always think of it as a demographic characteristic. So one of the things that I appreciate about all of these recommendations is we're including disability as a demographic category. And we recognize that we're going to have to spend money to do that. It's not simple to identify somebody's disability status when you're collecting data. So I just appreciate that that's been integrated throughout these recommendations. And to the extent we can get to a point where every time we're talking about disparities or equity, we're also talking about disability in that context. The data is going to be critical in order for us to do that. So that's all I have to say.
Thank you so much, Mr. Imperato. Dr. Venters, please.
Thank you. Thank you, Madam Chairwoman. Thank you to subcommittee leaders and members. I just wanted to point out that this world that we've been talking about of data, for people who are incarcerated, it's not that the data isn't perfect, it's that the data really doesn't exist. The most recent data we have about deaths behind bars at a national level comes from 2016. At that time, the leading cause of death in US jails was suicide. We do not have more recent data. And really importantly, that data is usually collected by law enforcement organizations and departments. And so this call from the subcommittee, and we hope up through the administration, for the creation of a broad approach to collection of this data is critical, and it must involve health organizations, public health organizations, to be involved in tracking and mitigating the health risks of incarceration. It can't just be law enforcement agencies coming up with data 3, 4, 5 years after the fact. That's completely not just substandard, but it really drives the disparities we're talking about here. So thank you.
Thank you, Dr. Venters. Chair Khaldun, anything else to add before opening up to the full task force?
Sorry, I couldn't get off of no, Madam Chair.
Thank you so much. Dr. Martinez, please.
Thank you, Madam Chair. Great presentation, Dr. Khaldun. I just would like to add and emphasize some low-hanging fruit, as sometimes it's called, when it comes to data that's already being collected. And it was brought up during our subject matter experts interactions that we had. Dr. Spiro Manson, as well as Dr. Donald Warren, brought this up, that the sharing of existing data is critical. So there's already data that we are collecting, especially at the CDC and Indian Health Service, that these researchers out in the community, as well as thinking about immediate impact the data can have in response to community, isn't easily accessible. And so I think there is some improvement that we can do in the process for already data that is being collected, so that our community members out there that are trying to make an impact on behalf of their communities. And these were two well-known researchers that are American Indian researchers, so a very unique group, and hence the reason CDC and the Indian Health Service. So just wanted to bring that point, that there's also good data being collected. I know we want to expand and improve, and we have identified that, but let's also ensure that it's being shared in a timely fashion in real time to really improve our response to a pandemic of this magnitude. Thank you.
Thank you, Dr. Martinez. Noted. Ms. Alvarez, please.
Thank you. Thank you, Dr. Khaldun, for the recommendations, and to the entire subcommittee. Just a question and a comment. One is on the recommendation that you put forward regarding an evaluation on the impact of the many policy changes that were made during this time. You rightfully call out the importance of housing policies and eviction moratorium and how that impacts our communities. I would also just encourage you to add the public health and healthcare related policy changes that were enacted during the public health emergency that have also contributed to stability for millions of people across the country. One being in particular, Medicaid enrollees have the opportunity to stay continuously covered under the program. They don't have to go through the barriers of being redetermined for their eligibility. And that particularly provides many of our families the opportunity to continue seeing their healthcare provider, to continue getting their preventive services. And so recognizing the importance of that continuous coverage, particularly for marginalized communities, for marginalized populations in rural areas, young children. Would encourage you to add just some health specifics to that, if that's okay. And then my comment, I just really want to commend you for calling out the importance of community-based participatory research in our data collection efforts, especially now, recognizing the importance of our community perspective and voice in this pandemic and how we can better collect that information in partnership with them, and also so that they can better own that data and utilize that data for their own benefit and advocacy in their state and local communities. Is so important. So really just want to commend you and the subcommittee for calling that out and bringing attention to the importance of community and research.
Thank you so much, Ms. Alvarez. Chair Khaldun, anything in response?
Yes, so thank you for all the comments, and for Ms. Alvarez, thank you for bringing up that specific point on Medicaid. It's actually, I think it just didn't make it to the slide, but it's actually really, really important, and it will be included. So thank you for bringing that up.
Wonderful, thank you. All right, unless I'm mistaken, I think we're ready to discuss the next subcommittee. Dr. Okafor, please.
Thank you, Madam Chair, and thank you again to our data analytics and research subcommittee. You did an excellent job with the recommendations, and now I would like to call upon our communications and collaboration subcommittee, and I will call upon the chair, Myra Alvarez, and she will present to you the exceptional work that this team did and their sets of recommendations. Thank you. I'll turn it over to Myra.
Wonderful. Thank you, Dr. Okafor. So I just want to start by thanking the members of the subcommittee, Andy Imparato, Octavio Martinez, and Vincent Toronzo, as well as the full membership of the task force for their thought partnership, and the HHS staff and interns for their incredible support. Just as a quick reminder, and in particular for those that are new to the task force, the Communications and Collaboration Subcommittee was created to explore how issues related to communications in all of its various forms and collaborations, both within the federal government and with external state and local partners, can contribute to a more equitable response to the COVID-19 pandemic and future pandemics. So, as it relates to the mental health impacts of COVID-19, the subcommittee identified 4 overarching problem statements. Oh, I'm sorry. Next slide, please. Thank you. So we identified 4 overarching problem statements to tackle through our recommendations. First, I think as has been shared by both speakers and task force, our fellow task force members, Americans are facing a confluence of crises, the pandemic, a challenging economy, ongoing racial injustice that are all negatively impacting our mental health and well-being, and that have also worsened an already pre-existing mental health crisis in the country, and that these challenges have actually exacerbated the very practices that have intensified inequities in mental well-being, including, as has been stated, criminalization of mental illness, suicidal ideation, and even opioid use. Second, building on this point, we call out that COVID-19 specifically intensified a pre-existing mental health crisis for children. And that is related to the result of school closures, social isolation, as well as dramatically reduced access to services and care, combined with the overall threat of the virus and the collective and individual grief over loved ones who have died from COVID-19 that have produced alarming mental health trends for children from birth through adolescence, and in particular for children of color. Children's distress, I want to call out, especially again for children of color, has also been intensified as public attention turned to the historical and ongoing racial injustice that has resulted in protests across the country. As part of this problem, our child-serving workforce, teachers, early learning and care professionals, and more are unprepared to respond to the wave of mental health needs in children and youth. Our third problem, and again, this does build on previous comments, is the reality that systemic racism is a root cause of mental health inequities, and the pervasive impacts of white supremacy has limited our system's ability to care for the well-being of Americans. And then finally, we call attention to the issue of social isolation, particularly as a result of the impact of physical distancing and stay-at-home orders, and how it has increased the presence of mental health challenges for many people. Additionally, since even before the pandemic, Americans were already extremely limited in the services, resources, and supports available to address mental health challenges. So we want to also call attention to that, the fact that, as a result, more Americans of all ages have relied on social media, community programs, and peers to support their mental health and well-being. So knowing these were the challenges, we identified a set of recommendations to respond in both the short and long term. So next slide, please. Thank you. So to respond to problem one, we have 3 recommendations. First, in order to leverage the reach of the White House, we recommend the administration maximize its unique reach to draw public attention to the pandemic emergency and the mental health impacts through known mechanisms like the president's weekly address, virtual fireside chats with leaders, as well as a prominent cabinet meeting. Again, the reach is incredible of the White House, and we want to make sure that this issue is front and center given the important impacts on the American people. Second, the federal government should support a robust collaboration between Health and Human Services and the Department of Justice to invest in alternatives to policing, including mobile crisis teams, but also releasing guidance on those alternatives, recognizing that there is important data that demonstrates the effectiveness of such alternatives, and then requiring greater integration of individuals with lived experience to determine how those funds should actually be utilized within the community. And finally, that the federal government lead a multi-pronged public-private mental health awareness, education, and communications campaign that actually centers equity and the unique impacts of the multiple pandemics on minoritized, marginalized, and medically underserved populations who have been disproportionately harmed by COVID-19. And this is repetitive of many already of my fellow task force members and their recommendation, and recognizes the critical reach of communications in many different areas that the task force is prioritizing. Next slide, please. To respond to problem 2, we have 10 recommendations that seek to leverage the power of both communications and collaborations in order to better center the needs of children and youth in our response to COVID-19 and in preparation for the future. So first, the White House should launch a comprehensive initiative to support the children of parents who have died from COVID, deaths that have disproportionately impacted Black and Brown children. The initiative will partner with local and national leaders, from philanthropy to business to faith communities to media, to address the broad and multidimensional challenges that are facing these children now and in the future as a result of those lasting mental health impacts of grief. The initiative is also, we also recommending that it create an interagency task force that will work across departments and agencies that will assess federal policies, regulations, and programs in order to improve access to mental health services and supports, as well as creating an online portal to disseminate practices and programs that improve mental health and well-being for kids and young people. Second, the federal government, through a robust collaboration between education and Health and Human Services, should offer guidance to school districts to inform the development of a comprehensive plan to address the potential mental health needs of their students. And we know that there are already important initiatives through the Department of Education underway, and want to recognize that and really call attention to the importance of continuing to provide such guidance. And then finally, the investment in school-based health centers, again, recognizing we need to go where our children are, where their families are, and school-based health centers are a critical resource for health services in the community, but not only for children that attend those schools, but also ensuring the centers are open to both students and their families. Next slide. The federal government should also fund a technical assistance collaborative and professional learning network, again, to support our early childhood learning, care, and development staff. This is again in response to the need to ensure our workforce is prepared to respond to the impacts of the pandemic, impacts that will be disproportionately impacting children of color, given some of the data that we know as far as expulsion rates from early childhood programs, suspension rates, things to that effect. We also recommend that the federal government invest in building states' capacity to support the hiring of more counselors and training of teachers and administrators on social emotional learning techniques. Again, recognizing just the importance of being knowledgeable, as many of our speakers talked about, being knowledgeable of what trauma looks like, how it shows up, particularly with those that are spending so much of their time with our children and young people. We also recommend that we invest in the availability of dyadic care models so that we're strengthening access to whole child, whole family mental health care services. Children are not taken care of in silos. They are part of families, they are part of communities, and recognizing that dyadic care models take care of both the child and the parent or caregiver together can help improve access to preventive care, to social emotional health and safety, as well as developmentally appropriate parenting and maternal mental health. And then finally, the federal government should invest in, oh, I'm sorry, not finally, the next one, federal government should invest in youth-led movements through grants for the integration of mental health into the programming of youth-led national organizations. We know there are organizations that are led by young people that are doing incredible work. How can we leverage their leadership by incorporating the importance of mental health in their work as well? Next slide, please. And then this last set of recommendation really focuses on what the federal government could be doing to strengthen our investment in young people. So one, requiring a youth mental health board, similar to requirements already in SAMHSA block grants, again, to try and ensure that that voice is there. Second, launching a national outreach and education campaign focused on young people, particularly Generation Z and younger populations, that would also include listening sessions across the country so that we get out of the Beltway and into our communities to hear from young people directly. And the campaign can utilize social media and other channels where the youth are connected, as well as leveraging peer-based programs. And then finally, the federal government should create the position of a youth health liaison to work alongside the U.S. Surgeon General so that there is uplifting of mental health impacts on young people in particular. Again, highlighting the leadership that young people are displaying and have displayed, but that is particularly more visible as a result of the power of social media and the news cycle. Next slide, please. To respond to problem 3, we have 5 recommendations that seek to leverage the power of collaboration to help address systemic racism and dismantle white supremacy that seeped in our policies and programs. Given the president's recent address to Congress and the American people, we're encouraged that these recommendations will build on an already strong commitment. First, that the White House host a syndemic symposium, these multiple crises, to draw attention to these multiple challenges, offer opportunity for dialogue and solutions, and highlighting commitments from across the government, as well as opportunity for input from state and local partners. As one of these commitments, second, we recommend that the federal government provide robust funding for community-based organizations to celebrate and build cultural identity in order to prevent mental illness and help address mental health impacts. This investment underscores the reality that trauma is intergenerational, that COVID built on already challenging circumstances for many communities, particularly many of the marginalized communities that have been talked about today, and that focus on culture and pride and identity is strongly connected to our overall mental health and well-being. Next slide, please. So as our presenter stated, there are programs that are working. So in the short term, federal departments should provide clear standards on best practices for reaching marginalized communities with mental health supports and services, and do so in partnership with national partners, highlighting successes of initiatives that we know have already worked. The federal government should require the creation of community advisory boards for mental health as a part of receiving funding. Again, this is a way to integrate community leadership, community voice, acknowledging that many of our programs already do this. How can we ensure that it's occurring across the board with all of the mental health initiatives that are funded? And then we also recommend that departments engage in a coordinated effort to fund peer support specialists, another form of community health workers that have been mentioned here today, including young people, to address the mental health impacts of COVID-19. Again, this is the idea that the elevation of a community workforce will strengthen our nation's capacity. It will supplement mental health and substance use treatment by licensed professionals and really aim to get at a more holistic definition of mental health services and supports. Next slide, please. And finally, to respond to problem statement 4, we build on previous recommended solutions and draw attention to larger systemic challenges that hinder support for mental health. So first, in leveraging the recommended federally led multi-pronged public-private mental health campaign, we really recommend the integration of the issue of social isolation and how it impacts Americans from all walks of life. Second, we believe communications should be utilized to launch a campaign around the availability, security, and quality of telehealth and its connection to the importance of accessing mental health services, recognizing the continued misunderstanding of telehealth amongst consumers, the fact that it's not a replacement, but it's a supplement, the language barriers and other limitations hindering Americans' access to telehealth-enabled support. And then aligning with this, third, we recommend that in the short term, the federal government strengthen access to broadband internet through President Biden's infrastructure plan. Again, to lessen the structural barriers for accessing mental health services via telehealth. And this is not only for rural communities, but frankly, for many people living in both urban and rural communities and the challenges that they face to high-speed internet and the capacity to be able to engage in these types of services. You will note our recommendations are both long-term and short-term. They're grandiose, they're specific, because we recognize that mental health implications are incredibly complex. We recognize it was a lot of content to cover and value the feedback and any questions. But before I hand it over to our Madam Chair to facilitate our discussion, I will open it up to my fellow committee members if they have anything to add. Madam, okay.
Yeah. Thank you so much, Chair Alvarez. Thank you. I see that I believe all of your subcommittee members have something to add. So we will start, we'll actually go with Mr. Imperato and then Dr. Martinez and then Mr. Toranzo, please.
Well, first, this is Andy Imperato. I just want to say I really enjoy this subcommittee and I want to give our chair, Myra, credit for creating a fun environment for us to think big when we think about communications and collaboration. I just wanted, the idea of a youth health liaison was something that I think for me was inspired by the youth poet laureate who we all heard speak, Amanda Gorman, during the inauguration. I think that was an illustration of the power of young voices in our country. And I think as we think about the impact of the pandemic on young people, and we look at the impact that Vincent Toranzo has had on this task force, we don't hear enough directly from young folks about the problems and the solutions related to mental health and other challenges facing young people. So I really strongly support that recommendation. I'm hoping that our Surgeon General can get excited about that and think about implementing that. And then I just wanted to lift up the recommendation about identity development or kind of learning about your culture as a strategy for being resilient and promoting mental health. You know, when I first got my diagnosis of bipolar disorder, it was very helpful for me to be around disability advocates who encouraged me to think of my condition as a natural part of the human experience, and to see myself as connected to a much broader community that has a history of experiencing discrimination and oppression and kind of coming together to fight that. So I'm hoping that as that recommendation kind of gets fleshed out, we can really think about how do you build a strong cultural identity for people with all kinds of disabilities, including but not limited to mental health disabilities, where they are proud of who they are, and they're not ashamed or embarrassed by the fact that they have a particular diagnosis, and they're connected to a broader culture that celebrates, you know, their identity. So I think that's a particularly visionary recommendation. I just wanted to lift that up.
Thank you so much, Mr. Imperato. Dr. Martinez, please.
Thank you, Madam Chair. Also want to give a shout out to my colleagues on the subcommittee and to our chair, Myra Alvarez. Great folks to work with and really a lot of critical thinking going on. I'd like to uplift the whole concept of, you know, public-private partnerships for communications and collaboration. I think that's really key for the United States, something that we can definitely do. But I also want to expand and ensure that we're including our nonprofits and philanthropy in that concept, because there are many organizations, many Americans who are ready to stand up and to really do some hard work. As an example, in just January of this year, the American Psychiatric Association formally apologized to the country for the role the psychiatry has played in perpetuating structural racism. and they've now started work groups internally and as well as holding webinars and things to start to actually put some action behind the words. And I think the truth also lies there with other nonprofits and of course our American Psychological Association, the presentations they just gave to us today, as well as there's a guild out there, the Grant Makers in Health, hundreds of philanthropic organizations dedicated to health, who I know because I am part of GIH through the Hogg Foundation for Mental Health, who are very interested and do want to do and partner with. So I just want to keep that and put it at front for us to be thinking about, and especially as we move this agenda forward, that there are many that really do want to partner with the federal government to make this a reality. Thank you, Madam Chair.
Thank you, Dr. Martinez. So we will note that under that umbrella, nonprofits and philanthropy as well. Thank you. Mr. Toronzo.
Thank you, Madam Chair. First, I just want to thank our chair, Mayra Alvarez, and the rest of the subcommittee. This has been a very exciting and productive committee, and I'm proud to be a part of it. And I just want to thank you, Mr. Imparato, for your kind words. So I think I'd like to believe that it's clear that the current administration strongly supports the idea of young people having a voice within all levels of government, but especially the federal government. So I just want to uplift the recommendations under problem statement number 2, where we want the federal government to collaborate with youth-led movements and organizations to try and tackle the mental health and behavioral health crisis we're experiencing in this country, and as well as establishing that youth health liaison position that can work alongside with the Surgeon General, which I think is extremely needed, especially when we're seeing how terribly this pandemic has exacerbated the mental health crisis amongst youth. And on top of that, just another note, I think it's best to recognize that younger generations, it seems as if they are really pushing for the destigmatization of mental and behavioral health, which I am very proud that they are doing that. And I think it's something worth noting and congratulating them for, and really just pushing them to do more to destigmatize, to further destigmatize the mental and behavioral health crisis we're experiencing. So thank you, Madam Chair.
Thank you, Mr. Toronzo. As we have time for perhaps one or 2 comments, if there are others from the full task force, anyone in the full task force? Wonderful. Chair Alvarez, anything that you would like to add?
No, thank you for the opportunity.
Yes, thank you. Wonderful. Dr. Okafor, I believe we have one more subcommittee.
Yes, thank you, Madam Chair, and just very inspired and amazingly impressive work being done by all the subcommittee. And it is with that same pleasure and admiration I'm going to introduce the last one. And that subcommittee is for healthcare access and quality. And I would like to introduce Tim Putnam, who will present to you exemplary recommendations that this group had to offer. Thank you. And Tim?
Thank you so much for the introduction and the support. I'd like to state that our subcommittee, it really is, you'll see the recommendations build on what many of the other subcommittees have faced, and there are common themes, and I will do my best to represent the fine work of the subcommittee, which is just an outstanding and committed team. Dr. James Hildreth, Vincent Toronzo, Mary Turner, Dr. Homer Venters, and Bobby Watts all put a lot of effort into the recommendations. We have almost 36 recommendations, so I will not go through them in detail, but want to give you color and insight into what our perspective is. So if you could move to the first slide, please. So the first 3 problem statements, one one thing that becomes very clear is access to mental care is limited. It's underfunded, there's a lack of payment parity, and it's exacerbated the inequality in care. Secondly, the shortage of providers is significant, but is truly underrepresented by people of color. It's always important to have diversity and representation, but it's more important in the behavioral health field due to the need for the patient to trust their provider and the provider to empathize with the patient. So although we need more people of color who are pharmacists and radiologists and pathologists, being able to empathize with that patient you're trying to treat is vital in the mental and behavioral health care field. The youth of the nation are at risk due to the impacts that they've experienced at a key developmental time of their lives. Events that are shared throughout generations, like proms and graduations and crowds cheering for your team, this group has lost forever. And we feel that the youth of the nation are specifically at risk for mental health issues. Next slide, please. The healthcare team over this past year and pandemic have experienced ongoing trauma. The burnout is rising among healthcare workers, and we're at the point of where we risk losing the very people we needed and trusted the most at the time of crisis. Likewise, substance use disorders patients trying to break their addictions have had their care disrupted in a way that's unacceptable. And we have to make a difference with those people fighting that very difficult addiction time in their life. And lastly, the last problem statement is being slow to recognize that the fact that we are a better, stronger, and safer nation when everyone has access to the care they needed has exacerbated this crisis. So moving on to problem statement number 1. We must assess and refine the payment system, recognize the value of treating mental health, and balance it against the costs associated with leaving it untreated. We need to recognize there are no cookie cutter solutions, and it's going to take hand-to-hand combat to be able to deal with the mental health crisis that we face. The next recommendations are specific to the needs of the Indian Health Service, the Native American community, and they involve improving telehealth in rural and remote areas and expanding that use and access, as well as, next slide please, increasing the number of inpatient facilities available to Native Americans, Pacific Islanders, and others. Next point is sadly too many of the at-risk communities only have law enforcement and force to respond to behavioral health crises. What they really need is a response based on behavioral health expertise. There are programs that exist that can be modified and can be extended, but when your only response is force, it's not going to get the results that we really need as a nation. Next slide, please. Many remote and rural areas have no access to mental health services. Telehealth is the only option and really needs to be expanded. We've proven throughout this healthcare pandemic that telehealth can be a viable solution in many areas. It's been studied, it needs to be detailed more, but is a viable solution to people who have no other access. There's also an importance to improve the housing and expand domestic violence shelters that are vital to people seeking safety during the pandemic and otherwise. So next slide, please. The final recommendations on problem statement 1 is immediate resources need to go toward people showing suicidal ideation. We need to use telehealth, training, and other resources that can promote the evidence-based tools that we have already to be able to be there as a rescue component for people facing a suicidal situation. Moving on to problem statement number 2. We need to significantly increase the number of culturally competent mental health care professionals. We need to be able to have more people understand and empathize with people who are different than they are and have a greater representation in mental health care professionals of people of color and other backgrounds. We also need to expand the peer support resources identified by earlier speakers and expand the existing mental health to expand the capabilities of mental health care professionals and use that as force multipliers. Next slide. Collaborative care models and others are another extension for that. Mental health professionals need to be able to work with primary health care providers to improve access. Many communities only have primary health care providers. They do not have mental health care professionals in their area. And using models like this can really improve the capability or possibility even that these people can get access to care. And then we also need to invest in programs that are proven successful with treating youth and families, not forgetting the parents. So problem statement number 3. Our nation's youth have gone through a challenging time during the pandemic. They've been deprived of important moments for which they'll never recover. I worry that the generational gaps that exist between every generation that's come before them will be even greater because of the lack of shared experience. We need to have formalized peer support programs because we have not walked in their shoes. Older folks have not experienced the same thing that they have, and they need to have formalized support programs from people that understand and can empathize with the challenges they've faced. Also need to have acute care services available, and the failure to invest in these services will have long-lasting impact on this generation. Problem statement number 4, please. Thank you. At the start of the pandemic, our healthcare teams faced a disease with little information and shortage of protective equipment, but they went in anyway. Throughout the pandemic, they've seen death take too many lives, despite their best efforts. They've been surrogate family members for people who could not receive visitors. They've been accused of lying about what they've seen during the pandemic, or that the numbers of patients they've been treated have not been what they've been told they have. The emotional trauma has been heavy. To borrow a phrase of people who have witnessed tragedy and trauma, they've seen the elephant and suffered in ways that only allow them to talk to people who've had similar experiences. We must set up a safe way for this to happen through other peer support networks. They also need to know that they can care for patients without risking their own lives and bringing this disease home to their loved ones. Next slide, please. People trying to break their addictions have suffered significantly during this pandemic due to disruption in their care. It's hard enough to break a battle, to fight an addiction and in regular circumstances, let alone during the pandemic. We're proposing several interventions that improve the continuity of care. We need to expand the effective harm reduction initiatives for these patients, for communities to have places for these people to be able to receive care, receive treatment, and receive support. It's very clear during the pandemic, people suffering from substance abuse disorder were not treated effectively, the tools we had available in the criminal justice system. We should not use law enforcement as a substitute for people who actually need addictions treatment. Which brings me to my final problem statement and recommendations. After a significant amount of time over the last month, looking into the mental health impact during the pandemic, it's become clear that our failure to recognize that healthcare as a human right has caused damage to this nation during the pandemic. Coverage remains inadequate and access is getting worse for many, as every 18 days, another small town loses their hospital and their access to care. It's time we recognize healthcare as a human right and align federal policies and funding to secure this right. Madam Chair, that is the recommendations from our subcommittee, open to questions, but I'd also entertain comments from the other members of the subcommittee.
Thank you so much, Chair Putnam. Very much appreciated. We'll begin with the members of your subcommittee. I believe Ms. Turner, you are first.
As a nurse and a patient advocate, I am so grateful to see healthcare finally recognized as a human right. You know, when a patient rolls into my ICU and we hook them up to the monitors, and those monitors direct the care that we give that person that's laying in that bed. Do you know what I see on that monitor? I don't see any differences. I see it's a human being, and they have a right to my care. But it's widely recognized in this country that major racial and ethnic health disparities are in our country. And I'm telling you, every day I see the effects of lack of healthcare access and the delay in treatment on my patients. And I have thought time and time and time again that this person could have avoided being in my ICU if they had had preventative care to begin with, if they had access, if they had had the right to healthcare. Thank you.
Thank you, Ms. Turner. Mr. Toranzo, please.
Thank you, Madam Chair. I'd like to first off thank our subcommittee chair, Dr. Putnam, and the rest of the subcommittee for being excellent colleagues of mine on this committee and giving really excellent expertise on what you all have experienced throughout your careers and your time evaluating what's been going on with this pandemic. So when discussing the mental health of youth, it is very important to recognize that with the potential loss of family members or friends during this pandemic comes trauma. And we heard that from our guest speakers earlier. Not only do we need to ensure that the accessible care is provided immediately, but also continue to provide that care in the future. So when discussing public health, society tends to forget to include mental and behavioral health within that discussion. And we have seen that by not aligning federal policies and funding to secure the right to healthcare prior to this pandemic, that has not only weakened our response to this pandemic, but also exacerbated the mental health crisis we're experiencing as a nation. And another point to make is that for many people, especially essential and frontline workers who are more frequently people of color, health insurance tied to employment has not been seen as a benefit, but rather as a liability and proof that our healthcare system has failed many Americans in this country. It's important to note that the right to healthcare has long been recognized internationally, and President Biden proclaimed in his address to a joint session of Congress 2 nights ago that it was finally time to reach a consensus that the right to healthcare access and coverage must be a human right. And as you heard from Dr. Putnam, it is now the opinion of this subcommittee that the task force recommends the federal government to recognize healthcare as a human right. Another point I will make, the last point, is that when everyone has access to affordable healthcare and affordable healthcare, they automatically become a stronger nation. We've seen that countless times, and it's time for our nation to meet that moment. So it's important that we need to meet this moment and act boldly for the current and future generations of our nation. Thank you, Madam Chair.
Thank you, Mr. Toranzo. Dr. Hildreth, please.
First, Madam Chair, I'd like to thank our chair, Dr. Putnam, for his kind and patient leadership with us. We can be a fairly rambunctious group, but he's very kind and patient with us. So I want to acknowledge and thank him for that. There have been many things that have happened over the last year that have led some leaders to say this is not who we are, that we're better than this, that this is not what America stands for. And running through all of it is the notion that all lives matter the same. Well, if all lives did matter the same, healthcare would be a human right, and every person living in the United States would have access to it. Until and unless that happens, all lives cannot matter the same. And I'm so pleased and proud that we have a president who stood in front of the joint session of Congress and declared that it was time for healthcare to be a human right. It is long since past that we do this. And I just want to say that of all the things that we've done in our subcommittee, having the courage and boldness to make that statement to me makes me really proud to be a part of what we're doing. So thank you for the opportunity. And again, thank you, Dr. Putnam, for your kind and patient leadership of our group. We really do appreciate you. Thank you, Madam Chair.
Thank you, Dr. Hildreth. Dr. Venters, please.
So again, thank you to our chair. Thank you to you, Madam Chairwoman. I also support the notion that I think is evidenced by reality that healthcare is a human right. I wanted, though, to offer a little precision about this notion that both the speakers earlier and also our subcommittee chair raised, which is that people who receive a law enforcement response to a health problem have worse outcomes. And this practice perpetuates and is the source of many gross disparities, racial disparities in health outcomes. But what I want to offer is that we cannot simply add health widgets to law enforcement structures. In other words, to simply add some amount of health apparatus under policing or law enforcement agencies is different than offering a categorically treatment response. And this is what I'm concerned about, both in community policing changes, but also behind bars, where new and better programs to offer, for instance, substance use treatment behind bars can quickly become subverted or can stop being evidence-based because sheriffs and commissioners of corrections decide what type of treatment is okay and what isn't. And so people need treatment responses for health problems, and we must have a very critical eye when extra funds and extra resources are going to law enforcement agencies, to courts, to criminal justice organizations and entities for some health-related reasons. If people have health problems, they need health care. Thank you.
Thank you, Dr. Venters. All right, appreciation to the subcommittee and the members. It is open for all the task force members. Dr. Khaldoon, please.
Really wanted to say thank you to this subcommittee. Really appreciate the recommendations. And also me as a practicing ER doctor, just wanted to say I absolutely 100% agree that healthcare is a human right. But I also wanted to put a finer point on it because I think healthcare is a human right, but also access to high quality, robust healthcare services is a human right. I've heard in previous years people talking about where anyone can go to an emergency department, so they have healthcare. Again, I'm an ER doctor. I do think everyone should have high quality access to emergency medicine services, but they also need access to primary care services. They need access to specialty services. And I think that's very, very important.
Thank you. Dr. Martinez, please.
Thank you, Madam Chair. A couple of comments. First, really want to commend the subcommittee, my colleagues here that are part of the subcommittee, just wonderful work, just outstanding recommendations you guys have brought forth for us all to consider. Also, I really want to thank President Biden and Vice President Harris for creating this task force, but especially you, Madam Chair, for recognizing the importance of mental health and substance use as cross-cutting issues. It really underlies and really brings to bear, I think, ongoing work to destigmatize mental health and substance use, when at this level we are recognizing that there is no health without mental health and substance use. And also, I'll just want to add my voice because I wholeheartedly agree with the comments made to declare healthcare access and coverage as a human right. It is time for us to stop considering it strictly a commodity, because as a commodity, it really then results in the inequities that we're seeing today. Thank you, Madam Chair.
Thank you very much, Dr. Martinez. Mr. Joseph, please.
Thank you, Madam Chair. First of all, I'd just like to really just thank all of our chairs for the great presentation, and also for the opportunity that I was able to work with Dr. Putnam on some of the issues that were important to me. And with that being said, I'd like to make recommendations to add tribe and tribal organizations to wherever states applied I think that would be really appropriate as we move forward with this final document. Thank you.
My apologies. Thank you very much, Mr. Joseph. A friendly amendment language include along with states, tribes, local jurisdictions, territories, please. Mr. Watts.
Thank you. I also want to thank our chair, Tim Putnam, and as Dr. Hildreth said, of Dr. Putnam for his patience in dealing with us. We really went back and forth with this. But I just really want to endorse the comment by Dr. Khaldoon about it's not just access, but access to quality care. That is what equity is. And I like to say without equity, we don't really have quality care. So equity for some, quality care for some is not really quality care. So just really endorse her comment as we lean into healthcare as a human right, that is about quality and equity for all.
Thank you very much, Mr. Watts. Chair Putnam, any additional thoughts?
No, just very proud of the work that this group did. It really took a lot to get through the monumental task. So much of what we've seen during the pandemic has had this mental health impact. The only thing I'll say is if we do not address it, if we do not put effort toward it, there will be lingering impacts. And also just really proud that we had the long discussions about healthcare being a human right and what that means to this nation. So thank you very much, Madam Chair. That's all I have to add.
Wonderful. Thank you. Thank you very much to all four subcommittees, to the subcommittee chairs and the members. Outstanding work. We will take the slate up for vote later on in the meeting. Right now, we will pause. We will resume at 5:20 Eastern Standard Time for public comment. Wonderful. Welcome back, everyone. And this time I'm going to turn it over to Dr. Nguyen. Thank you for public comment.
Thank you, Madam Chair. So we received 6 requests to deliver public comments. First, we will hear from Ms. Thea Monnier from Health Equity Policy Group. Please go ahead and unmute yourself if you are on Zoom, or *6 if you are on phone. Ms. Monnier, you have 3 minutes.
Thank you. Good afternoon, and thank you to this committee. My name is Thea Monnier, and I am honored to speak as a representative of the Health Equity Policy Group. This group is a cohort of Black female health, mental health, research, biomedical, legal, substance use, behavioral, and community engagement strategists. Our focus is to address health inequities and disparities in Black America. Thank you for all the work and expressed intentions shared here today. It is exciting to hear. Mental health in America can be used as a mirror to reflect who we are as a society and what we value. The Black community's conflict with America's mental health system is not solely due to stigma or faith-centered beliefs and practices. It is due to righteous suspicion. The American mental health system is designed from a Eurocentric model and value system focused on the individual rather than an Afrocentric system of integration where everything is connected. So what is the challenge? The current mental health model is designed at best to teach Black bodies to cope with systemic oppression, violence, and inequity, while simultaneously educating and training practitioners to believe they are incapable of harboring bias or being a tool of a systemic racism system. One example is how providers of color are scarce and are trained within a system centering white clients and their cultural norms. Another is how practitioners are discouraged from implementing culturally relevant healing practices unless they are sanctioned and deemed acceptable by white leaders in the mental health field. Some of the solutions could be creating mental health resources and models that understand that Black communities thrive in spaces that center their cultural values, including creativity, community, and spirituality. We deserve to see our community members and values integrated into this current model. The mental health field must shift from neutrality to directly addressing systemic oppression in and out of the therapy room in order to meet this standard. We recommend mental health professional associations and governing bodies seek, attract, and retain diverse cultures, perspectives, and beliefs to create and implement culturally and socially equitable guidelines, ethics, policies, education, standards, assessment tools, and treatment that are created for and by us. We must make joy the baseline standard for all areas of health when engaging with Black communities. Create a modifier for racism within the DSM, naming it as undoubtedly the most stressful environmental factor Black America is facing. In closing, the current individualistic model of mental health fails to acknowledge the impact of systemic racism on Black bodies, which includes micro-invalidation, microaggression, and micro-inequities. We cannot equitably address the mental health needs of Black people in America unless we begin by valuing them in all areas of society and acknowledging that the #1 problem Black communities face in America, including in mental health, is white supremacy. Thank you so much for this opportunity.
Thank you, Ms. Monnier. Next, we'll hear from Mr. Kenneth Westbury from the National Coalition of STD Directors. You have 3 minutes. If you are on phone.
Thank you, Hannah. Yes, I'm on phone when in DC. My name is Kenneth Westbury. I'm with the National Coalition of STD Directors. The health membership organization that represents public health departments, STD directors, public health leaders, including disease and nurse specialists and contact tracers, partners in all 50 states and territories. We commend the Health Equity Task Force to its leadership and its sustained prioritization on the needs of traditionally underserved minority communities and those most disparately affected and impacted.
You are disconnected, Mr. Westbury. Perhaps we can receive a written comment from you if you cannot log back on with us during this session.
Yes, and I will conclude by saying that mental health workforce and the STD workforce are best suited to addressing some of the needs of the most underserved communities. Eligibility expands and redeployment of the STD workforce persists. Capacity exists, and the STD disease intervention specialists and directors can best sustainably
We can't hear you again. We will follow up with the written comment so that we can include in the meeting minutes. Thank you, Mr. Westbury. Next, we will hear from Ms. Victoria Veltri, Connecticut Office of Health Strategy. You have 3 minutes.
Good afternoon, Dr. Marcela Nunes-Smith and members of the COVID-19 Health Equity Task Force. I'm here on behalf of the state of Connecticut and our Office of Health Strategy. Our mission is to implement comprehensive data-driven strategies that promote equal access to high-quality healthcare, control costs, and ensure better health for the people of Connecticut. I'm not going to read my full public comment that I submitted to you, but I will highlight a few areas. One is you have made an interim recommendation on mandating data collection, harmonization, and integrity in collaboration with marginalized communities and practitioners. We couldn't endorse that proposal more. While your proposals are tied to the disparities particularly faced by communities of color and disabled individuals during the pandemic, I urge you and we urge you to recommend such data collection across all settings on a permanent basis. The collection of such data has been a priority since our office's inception and aligns with our Governor Lamont's priority on addressing equity. Communities in Connecticut are experiencing serious disparities in clinical and population health outcomes, and communities are suffering disproportionately on maternal morbidity, asthma, diabetes, and particularly in COVID-19. Disparities by disability and insurance status are well documented. In some counties of Connecticut, over 65 languages are spoken. We're no different from other states in this regard. And in some cases, our disparities are worsened by substantial economic inequality. Without standard and uniform data collection, we cannot understand, identify, and target resources and optimal interventions and solutions to the disparities that exist. In Connecticut in 2021, our office introduced legislation to clarify and standardize race, ethnicity, and language data collection for hospitals and healthcare providers required to connect to our state's health information exchange. And that includes meaningful disaggregation to address long-standing issues of racism and implicit bias in healthcare delivery and healthcare systems. Our proposal doesn't mandate that patients provide this information, but hospitals and health providers must request it and include these data in their electronic health records for inclusion in the state's HIE. While reporting is critical for discrete public health uses, such as vaccine and testing reports, a focus on collection by providers as part of an HIE has the promise of a farther reach and interaction with other data sources, such as immunization registries and state agency data collection. Disaggregation is the key to making communities and their unique experiences visible in addressing ongoing structural discrimination. Quick example, in Connecticut, we have a large Cambodian American community, which many are survivors of the Khmer Rouge. Their experiences and some of their common health conditions, PTSD, diabetes, hypertension, high suicide rates, and high early mortality rates would be very different from other Asian communities in Connecticut who have their own unique experiences. OHS proposed this language on statewide HIE self-reported data collection that included disaggregation among multiple categories, including the choice to select multiple ethnic or racial designations and the required collection of primary language data. We know this is possible because we've done it in Connecticut, and we are trying to recommend it that providers collect it more uniformly across the country and in our state, but they need resources and they need help to do it. Lots of healthcare providers and health systems can do this on their own. Hartford Healthcare has done it in Connecticut, but they need the support. Lots of smaller providers need resources. So we wholeheartedly endorse your recommendation to provide resources at a federal level, including the kind of technical assistance to help providers understand how to collect this information, how to interact with patients, and how to use it in reporting for reporting purposes. Obviously, these data are critical at an aggregate level to target interventions and direct resources in the future. So we are very supportive of this work. We are actually developing a health equity trust here in Connecticut to address upstream interventions, and the collection of these data are critical to that work. Finally, I will close by saying we are more than willing to be a partner with you as you move forward. We're happy to do that and support your work. And I want to say, just as a person who's been listening for the last 2 hours, that the issues that you've discussed during the meeting so far are very near and dear to my heart in the state of Connecticut, as we address them routinely on a daily basis. So we also are very happy to see the recommendations coming forward in the areas you've addressed today. So again, thank you very much for the opportunity to be here, and thank you so much for the work you're doing.
Thank you, Ms. Veltri. Next, we will hear from Ms. Jessica Halem from the Tegan and Sarah Foundation. You have 3 minutes.
Thank you. Thank you so much. I'm sorry to disappoint any of you that were hoping that Tegan or Sarah, the world famous pop stars and queer icons, would be here today. But I am proud to be representing the entire board and staff of the Tegan and Sarah Foundation, whose mission is to improve the lives of LGBTQ women and girls. With the help of our amazing network of small and grassroots grantees and partners, we recently fielded an online survey focused on the LGBTQ community and the COVID-19 vaccine. And I wanted to share some early results with you right away. My comments today and the full report that you have access to will focus on 3,338 respondents who were 90% LGBTQ and who provided a US zip code between the dates of March 31 and April 13. So I'm going to highlight 3 bright spots today that I think we could all use and maybe learn from as well. Number 1, the US LGBTQ population is highly accepting of the COVID-19 vaccine. In our survey, 68% were already vaccinated. That means that 2 out of 3 of our respondents had already been vaccinated by mid-April. This is fascinating because our respondents were disproportionately younger, right? Under the age of 55. This may be, of course, related to the increased likelihood that LGBTQ people work in industries that were highly affected by the COVID-19 crisis. Much more research is needed here. Of the remainder, 84% want to get the COVID-19 vaccine as soon as possible. So let the public record show that the gay community is excited about summer. Bright spot number 2, gender minority people, which includes those who identify as non-binary or transgender, were the most likely of all of our respondents to want to get the vaccine as soon as possible. Given the lower levels of healthcare among and access among gender minority people, what can we learn from this story, the success of this vaccination effort among those who are gender minority? Perhaps lowering the barriers to life-saving medications and screenings works. And perhaps this sort of drive-through nature of most vaccine sites offers less misgendering and trauma for trans and non-binary people. And number 3, and really the headline for today's story, is that the message was clear. Wanting to protect others is the most important reason cited by LGBTQ people who have gotten vaccinated or who will get vaccinated. This was substantially higher than among cis and straight people. And of course, this is the LGBTQ story, that even after our long history of trauma and discrimination, and now once again, we are being used as political football on the state level, We care deeply about the health of each other and will do whatever we can to protect our community. Finally, because sexual orientation and gender identity, or what we call SOGI data, are not collected in real time, the impact of COVID-19 on the LGBTQ population is less understood. I know all of you hope that we will fix this data issue quickly at the federal level. Thank you all so much for having me.
Thank you, Ms. Halem. Next, we will hear from Dr. Pat Franklin, private practice physicians. You have 3 minutes. Dr. Franklin. Okay. Next, we'll hear from Mr. Robert Huden from Team Vaccinate. Mr. Huden. If you aren't, please unmute yourself. All right. That concludes our public comments. Please note that written comments will be accepted up to 7 days after this meeting. Please send the comments to COVID-19 HETF@hhs.gov. Back to you, Madam Chair.
Thank you, Dr. Wendt. Thank you to everybody for public comment. We will turn to voting on the interim recommendations in just a moment. Before we do that, I would like to ask Dr. Okafor if you could take a few moments to acknowledge the work of the subject matter experts who have been working so closely with the subcommittees.
Okay, thank you so much. I don't know if, I know there is a weather problem in DC, so as a result, Katie cannot share the slides. Could you see the slides? Oh, no.
At this point, we do see the slide deck. It's, yes, I believe it is coming.
All right, so what I'll do is actually get the slide deck back to the, I think it's last, right? Do you still see it or no?
No, the slides are no longer visible.
Oh, I'm sorry. Okay. Let me see. Could you see it now?
Yes, we do. It is not yet in presentation.
Sorry, not in presentation. When I do that, it moves back to an old slide. Anyway, so I'm not going to waste everybody's time anymore. I wanted to share, we have a weather issue in DC, so for some reason cannot, the person sharing the slide is not in a position to share it, but I wanted to acknowledge that more than 21 subject matter experts that were involved with the task force this month. This information, the PowerPoint presentation, will be made public, and for viewers as well as those listening, you will be able to see all the subject matter experts on the slides that we identified because we wanted to appreciate their work and their contribution. I also wanted to make a note that most of these accomplished recommendations that you heard about, that we had staff behind the scene backing up this work. And these great talents of staff, I just wanted to say thank you to all of them and to appreciate all the work from Katie to Josephine to Cherise to Min to Bonnie. All of you actually played great role in doing this work, as well as those that I didn't mention. So there are so many hands behind the scene contributing to the work. And I just want to say that we greatly appreciate all of you, OH staff and everybody. Thank you. And I'll turn it over to Madam Chair.
Thank you. And let everyone please be safe with the weather issues there in DC. So we will turn now to voting on the slates of interim recommendations. Just a reminder for everyone, we do consider these slates by subcommittees. We'll take each one in turn in the order in which they were presented earlier. For everyone viewing, again, these are interim recommendations. The vote allows the subcommittees to continue to work on these recommendations. They may be modified before presentation and inclusion in the final report. So with that, we will take up for consideration first the slate of recommendations presented by the Structural Drivers and Xenophobia Subcommittee. At this point, I will entertain a motion on that slate.
So moved, Madam Chair.
Thank you.
Second.
Thank you. We have a second from Dr. Martinez. Any further discussion? Hearing none, please signal your votes by raise of hand. Ayes.
Aye.
Thank you. We'll take one moment for the reporters.
And this is Dr. Venters. I vote yes.
Thank you, Dr. Venters. Thank you. I will call for any nays. Any abstentions? I vote yes, the motion carries. Thank you. Next, we will consider the slate brought up by Data Analytics and Research Subcommittee. Please, I will entertain a motion at this time.
So moved.
Thank you very much, Mr. Imperato.
Second, Madam Chair.
Second, thank you, Mr. Joseph. Any further discussion? Okay, hearing none. Please signal with show of hands. Ayes.
And this is Dr. Venters. I vote yes.
Thank you, Dr. Venters. All right. Thank you. Any nays? Abstentions? I vote yes. Thank you. Motion carries. Next, we'll consider the slate of recommendations put forward by Communications and Collaborations. Please, at this point, I would entertain a motion.
So moved.
Thank you very much, Dr. Martinez. Is there a second?
Second.
Thank you very much. Any further discussion? Hearing none, please signal with show of hand. Ayes.
And this is Dr. Venters. I vote yes.
Thank you, Dr. Venters. Thank you. Any nays? Any abstentions? I vote yes. Thank you. That motion carries. We have one additional slate of recommendations to consider. The slate of recommendations brought forward, again, interim by Healthcare Access and Quality Subcommittee. At this point, I would entertain a motion.
So moved, Madam Chair.
Thank you very much, Mr. Toronzo. Is there a second?
Second.
Thank you very much. Mr. Watts, any further discussion? All right, hearing none, please signal show of hand. All in favor?
And this is Dr. Venters. I vote yes.
Thank you, Dr. Venters. One moment, reporters, please. Thank you very much. Any nays? Abstentions? I vote yes. Thank you very, very much. That motion carries. Wonderful. Congratulations, task force. We have a slate of interim recommendations. Thank you so much for the hard work that went into them, and of course for the work that will continue to go into them as those recommendations return to subcommittee. I will just have a few words for us. Again, as Dr. Okafor began, to continue our thanks as we prepare to conclude what is our third meeting of the COVID-19 Health Equity Task Force. Especially, I cannot ever say it enough, the work that is done in subcommittee it's a lot, and people are incredibly committed. The work is tireless. Thank you to each and every one of the chairs for your outstanding leadership of the subcommittees, and for each of the members for the deep level of engagement with your approach to the work. Today, we considered and voted unanimously on recommendations that were insightful, actionable, thoughtful, all. So much appreciated. Of course, for our speakers today, I thank you. Thank you very much to Assistant Secretary Levine for those comments and updates from HHS. Thank you to Dr. Evans, Akbar, as well as to Dr. Karnick, and all of those many subject matter experts, as we talked about, and stakeholders who are providing us with invaluable insights. Thank you very much, Dr. Okafor, our Executive Director for the task force, Dr. Wet, our DFO, the entire federal staff team. As Dr. Okafor says, it takes many, many, many people to support this work. We have deep gratitude, much appreciation as well to our ASL interpreters. Thank you so much. It's important to us that these meetings be accessible. Our next meeting will focus on xenophobia and discrimination. The date and time will be provided when the meeting notice is published. So look for that in the Federal Register. It will also be posted on the task force website. Thank you, extraordinary work all. Thanks again, of course, to all the public comments. Everyone have a safe weekend. Much appreciated. With that, we are adjourned.
Thank you. You all have a good night.